Good morning, everyone. Thank you for joining us this morning for our third annual Liver Cancer Conference. I'm Susanna Masardis, CEO for the Community Liver Alliance. And on behalf of the CLA's Board of Directors and our staff, we thank you so much for being a part of our annual conference. We have an amazing lineup of speakers for you this morning to share their time and expertise to educate us today. We thank you for being here and being a part of this. I want to remind you that today's conference offers CMEs from the University of Pittsburgh Continuing Medical Education Office, and the CME information will be sent to you post-conference. We also ask that you take a few moments to complete the online evaluation, which can be found on the evaluation tab. The evaluation helps us to understand what you thought about today's program, and more importantly, to let us know what you think we can do more or better, and we want to be able to continue to support you as we are planning our important education programs. We also want to thank our generous sponsors and exhibitors who not only bring us therapies and cures for liver patients, but also make it possible for us to provide this conference free of charge to our provider community. So please be sure to visit the sponsors by clicking the sponsor tab. We have a special time from 12:30 to 1 to do so. And we want to mention Allegheny Health Network, Highmark, the Pittsburgh Liver Research Center, AbbVie, our national sponsor of distinction, AstraZeneca, Bristol Myers Squibb, ISAE, Exelixis, Genentech, Merck, Servier, and of course UPMC. And it's my pleasure to introduce our course directors. I want to thank Dr. Dulab Monga with Allegheny Health Network and Dr. Paul Monga with the Pittsburgh Liver Research Center. They've been our course directors for these last 3 years and have helped us to craft really great education, put together some amazing speakers, and it's my pleasure to call them our colleagues and friends. Please help me welcome Dulab and Paul.
Thank you so much, Susanna. Really appreciate the opportunity to be here. I'm Paul Monga. As was mentioned, I'm the director of the Pittsburgh Liver Research Center, and I'm also a professor of pathology and medicine at UPMC. You want to just...
Hi, everyone. My name is Dulab Monga. I'm a medical oncologist at Allegheny Health Network. My area of expertise is in GI oncology. And I'm super excited to be here today to moderate this conference along with Paul. We have wonderful speakers, and hopefully everyone will gain something from this conference.
Awesome. Thank you, Dulab. So as was mentioned by Susanna, this is our third annual kind of conference, and the first time we had it in person, and then after the pandemic, we didn't stop. We did a virtual one, I thought, which went pretty well last year, and then this is the third, and we are hoping that it's going to be in person, next year. So please get vaccinated, help us meet our goals, and get us to the next level. I would like to thank again Susanna for her generosity for bringing people together, continuing the mission of education and public outreach. That's very relevant. We'd like to thank Amy for all her help in logistics, Amanda and Colleen from both Dulab and my offices. They have been wonderful and were able to help us bring all of this program together. And I would again echo what was said by Susanna. Would like to thank the sponsors whose generosity is very clearly visible. And we hope that during the lunch session, our audience and all the speakers are able to visit the booth, that is virtual, but there would be some important information that you will all gather from those sponsors. Of course, this program would not be feasible without the lineup of wonderful speakers. We have representation from both University of Pittsburgh Medical Center and Allegheny Health Network, and you're going to hear very, very relevant talks on diverse topics with the central theme of hepatocellular cancer. And we'll have also Dr. Mitesh Borad from Mayo Clinic from Arizona, Scottsdale campus, who's also going to provide his perspective on the new therapies in this area. So before we begin, just my final thoughts would be that we want this session to be dynamic. We want a lot of interactions. So please feel free to put your questions in the chat box, and we as moderators will do our best to relay those questions to the speakers. And we do want to have a robust discussion at the end of each talk. It's a 25-minute talk and 5 minutes for Q&A. And then you'll see that there's going to be 3 case presentations post-lunch. And Dulab, maybe you can talk a little bit about that, and then we can kind of get the program started.
So we have our wonderful budding hematology oncology fellows and a hepatology fellow who will be presenting 3 different types of cases, and our panel of speakers will discuss the relevant points of each case and teach us how to manage these complicated cases that we see on an everyday basis. So please stay put till the last presentation, because that's when the cases are going to happen. And I'm sure you will all enjoy that discussion.
Awesome. Well, great. I think we still have a few minutes, and then I think we can maybe wait for a few minutes, and then Dulab can introduce. I think we'll start at maybe in another 2 or 3 minutes rather than 8:30. That'll allow us probably to give us some flexibility with some more question and answers, So maybe in the next 2 minutes or so, we can get started. So just kind of hang in there for a few, and we'll be back. Thank you.
Thank you. Good morning, everyone. Welcome to the third HCC Community Liver Alliance conference. And I have the honor of introducing our first speaker, Dr. Sudarshan Pal Singh Monga. He is the professor and vice chair of pathology and director of the Pittsburgh Liver Research Center, University of Pittsburgh, and UPMC. Dr. Monga, please take it away.
All right. Yeah, thank you very much for this opportunity. So I thought I'll start by, the talk on how does the liver cancer develop. And these are my disclosures. So liver cancer is a major unmet clinical need. And these are some of the numbers here for the worldwide incidence and mortality. As you can see, liver is among the top 5 prevalent wide for breast, lung, colorectal, and prostate. From a number of deaths perspective, it's the third most relevant cancer in terms of mortality. These are numbers from 2020. In the United States, it is the 13th most common tumor type and the 6th commonest cause of death. And while it's only representing about 2.4% of all cancers, the concern has been a gradual increase in the incidence of this cancer over the last couple of decades. And similarly, there is increased mortality associated with this cancer, again seen over the last few decades. In 2020, the estimated number of new cases in the United States was about 42,810, and about 30,000 cases are expected to, they actually died due to liver cancer. The 5-year survival is less than 20%, and hence it remains a major unmet clinical need. Some important facts about hepatocellular cancer. It is a primary liver tumor. It's the most prevalent primary liver tumor. It's sexually dimorphic, occurring about 2 to 3 times more in men than women. And one important aspect of liver cancer is that it doesn't develop in a healthy liver. About more than 90% of the times, there is an underlying chronic liver disease, and these patients have advanced fibrosis or cirrhosis. Occasionally, liver cancer can occur de novo in the background of a relatively healthier liver. And one such instance is of a neoplastic transformation of a benign tumor, hepatocellular adenoma. These hepatocellular adenomas that would progress to liver cancer have been now very well characterized. They are the ones that are carrying a specific mutations and also occur in an inflammatory milieu. But we are not going to discuss too much of that subtype of tumor. Another variant of liver cancer that we are not going to discuss much about today is the fibrolamellar variant, which is very distinct disease. It usually occurs in younger adults who have no prior history of liver disease. And again, there has been a lot of work done in molecular characterization, and in more than 90% of these fibrolamellar variants, there is one particular fusion gene that has been identified to be the driver of this specific tumor type. Hepatocellular cancer is also distinct from hepatoblastoma, which is a pediatric liver tumor. In children, you can get both hepatocellular cancer and hepatoblastoma, and although both are relatively rare, the HCC in pediatric patients also occurs in the setting of chronic liver disease, whereas hepatoblastoma occurs in a relatively healthy liver and is the origin of this tumor is very distinct and is thought to be due to defects in differentiation of liver cells or hepatoblasts, and which are then suspended in specific stages of differentiation and continue to proliferate and lead to this type of a tumor. As I mentioned, hepatocellular cancer typically occurs in the setting of chronic liver disease due to any of these etiologies mentioned here in the left corner box, due to either viral infection, HBV, HCV, due to chronic alcohol-associated liver disease or non-alcoholic fatty liver disease, or other cholangiopathies, etc. The normal liver is undergoing injury, and as a result of this, there is wound healing response, which is the early fibrosis, which then continues to progress if the disease or the injury continues to occur, to result eventually in cirrhosis. Cirrhosis is a known risk factor for the development of hepatocellular cancer, and I'll talk about the underlying cellular machinery that leads to HCC and the molecular drivers that lead to HCC in the next forthcoming slides. But what's important is that this chronic insult that eventually leads to hepatocellular cancer can occur over decades. It can take anywhere from 5 to 50 years for liver to undergo this kind of injury, which then eventually results in cirrhosis and liver cancer. And again, as I said, it's a very protracted course, making the relevance of surveillance of patients who are at high risk of this neoplasia to be a very important part of management, because early diagnosis is critical in a disease like this, because the surgical management is really the only precision-based medicine that is available in HCC. And we'll be hearing a lot from Dr. Obaid Sheikh and from Dr. David Geller about those early surveillance and early intervention for therapeutics of liver cancer. So because of that protracted course, the age-based incidence of HCC is evident usually beyond 50 years of age in a patient. So most of HCC is seen in older patients, again, because it is taking a long time for the liver injury to occur and eventually leading to fibrosis and advanced cirrhosis. And just because most HCCs occurs in the backdrop of chronic liver injury, it is a challenge to take care of these patients because you are treating not just one disease, it's not just one tumor, it's also the underlying liver disease. So it's two diseases rolled into one. And hence, when an optimum therapy is identified for a liver cancer patient, it has to take into consideration the underlying liver disease, the stage of that liver disease, the performance of the patient from a liver perspective, as well as the size and the nodularity or the invasive sort of stage of tumor. So just a simple classification does not do the job well to take care of these patients, and hence there have been many different ways these tumors have been classified to provide best care to a liver cancer patient. And this is just an example of BCLC or Barcelona Clinic liver cancer staging, which you're going to be hearing more about in later talks, especially from Dulab as well. So this is probably the most relevant slide, which is going to talk about the cellular mechanisms that are relevant and lead to the development of hepatocellular cancer. So due to any of these pathologies that I mentioned up there, alcoholic liver disease, NASH, and hemochromatosis and cholangiopathies, etc., there is chronic insult to the liver. And what I mean by that is that the cells that are injured within the liver are hepatocytes, and which are the major functional cells or functional units of the liver. And what that does is this is a simple tunnel staining on a liver in red, and you can see the cells are dying when they are chronically injured. But as a result of this, the other liver cells or hepatocytes that are present around that dying cell will get a signal from these dying cells to now proliferate so that they can compensate for the lost cell. So there is this bout of liver regeneration that happens when a cell is dying. Because it's a cell death and cell proliferation event, that's what constitutes a wound healing response in the liver, because liver is injured and now it has to be replaced by some scar tissue. And because of this ongoing injury and regeneration, a lot of immune cells, neutrophils, lymphocytes, macrophages are brought into the parenchyma, and stellate cells, which are yet another fibroblast-like cells, which then generate collagen to form a scar in the liver, are activated. There is associated endothelial cell dysfunction, and there is also production of reactive oxygen species in this microenvironment. And this whole sort of cycle of injury, repair, and inflammation, fibrosis happens for many, many years. And eventually, if those cells are proliferating in this very adverse environment, there begins to occur DNA damage in the hepatocytes. And one of those forms of damages is the occurrence of mutations. When some of these mutations occur, if that specific mutation is able to give a survival or a proliferative advantage to a cell, then that cell begins to grow as a clone, as is depicted here on the right, where this green cell has just accumulated a pro-survival mutation because of either an activation of an oncogene or loss of a tumor suppressor. And then this particular clone of cells begins to grow and eventually results in a formation of neoplasia. And once this tumor forms, it continues to progress and becomes more heterogeneous. Rarely you will find a subset of hepatitis B patients, aflatoxin patients, and even subset of NASH patients, which are going to skip these years of insult, and through some direct DNA integration effects, for example, of hepatitis B, it can directly cause either suppression of some tumor suppressors or mutations in an oncogene to activate this survival pathways, and then you can get the development of liver cancer without any advanced cirrhosis. In other words, you can begin to see neoplastic lesions even when the liver is not fully fibrotic or cirrhotic. So this truly is the cellular basis of HCC. And how does this look like under the microscope? I'll just give you an example of non-alcoholic steatohepatitis, because this is one of the most prevalent disease in the Western world when it comes to the liver, because of obesity or because of other metabolic syndrome associated pathologies. 30% of our population in the Western world has some degree of steatosis, which means there's accumulation of lipid in hepatocytes, which is seen as these clear areas on tissue section. About 10% of these patients are going to progress to NASH, from simple steatosis to non-alcoholic steatohepatitis, which means that in addition to now fat, you're going to begin to see a lot of these immune cells that are present. And this is how we classify the development of non-alcoholic steatohepatitis. And 25% of these NASH patients are going to progress to full-blown cirrhosis. And you can see this here by staining for Sirius red or trichrome, which is a marker of collagen. And you can see these blue areas around the different hepatocytes. And then a subset, about 10 to 25% of these cirrhotics will progress to HCC because this is a clone of cells that have now been able to survive and expand in this very adverse microenvironment. And very rarely you will skip the development of cirrhosis, and a subset of NASH patients are going to evolve into HCC without growing through this. And the molecular mechanisms behind this are still not fully understood. But what has also been very relevant is that there is a slight increase in the incidence of a type of cholangiocarcinoma or bile duct cancer in these NASH patients. And you can see that there is that these patients with NASH are at a slightly higher risk of developing intrahepatic cholangiocarcinoma, which is something that I'm not going to go into detail. So the question then becomes, what are some of the earliest alterations that occur over time that give these clone of cells a survival advantage? And this has been addressed by doing exome sequencing or RNA sequencing on different stages of liver in patients. People have examined healthy liver, cirrhotic liver, low-grade dysplastic nodules, high-grade dysplastic nodules, and eventually hepatocellular carcinoma. And one of the earliest events that is observed in these patients which show low-grade dysplastic nodule are mutations in TERT promoter. About 5% of the cases have shown TERT promoter mutations, and in a high-grade dysplastic nodule, this incidence is higher. And as soon as you begin to see hepatocellular carcinoma begin to occur, you begin to see additional mutations in genes like beta-catenin, p53, and others. In fact, there are about 40 to 60 mutations that have been observed in hepatocellular carcinoma on average once it's diagnosed. But what is very relevant is that the top 3 genes that are most prevalent in their mutations, the TERT, which encodes for telomerase, p53, and CTNNB1, which encodes for beta-catenin, also have shown a trunk role in liver cancer development. What do we mean by that? It means that these are the mutations that are observed even in the smallest of HCCs, meaning the earliest possible lesions, which kind of give you an indication that these are drivers of liver cancer. Then there are mutations. These are also the mutations that are present in different regions of a large tumor. If you have a larger tumor and if you sample 3 different areas or 4 different areas, if it's a true trunk mutation, it'll be positive in all of those areas. And finally, if you have a multinodular disease or a metastatic disease, if these trunk mutations are commonly present in the primary as well as the metastatic event, or if it's a multinodular disease, the same trunk mutation is present in all different nodules, again indicating that these are really the major drivers of liver cancer. So if you summarize the various mutations in HCC, you can see again that there are all these mutations. The most frequent mutations are TERT promoter mutations, followed by beta-catenin, followed by p53, and then there's smattering of all these different other oncogenes that are known to be mutated, or tumor suppressors that are known to be mutated. And these 3 mutations, TERT, beta-catenin, and p53, again, are the ones that are the most abundant in all liver cancers. So the next question is there any enrichment of mutations based on etiology or underlying etiology of liver disease? And the answer is, in some cases, yes. For example, when you're looking at hepatitis B virus, there is overrepresentation of mutations in IRF2, in p53, MLL4. If you're looking at alcohol, in alcoholic liver disease-associated HCC, there's overrepresentation of telomerase, there's ARID1A mutations, and also beta-catenin and SMARCA2 mutations. There are no specific enrichments that are observed in HCV, hemochromatosis, or in metabolic syndrome, where, again, the most frequent events continue to be TERT, beta-catenin, and p53, among others. So based on all of these high throughput omics, multi-omics analysis, we have been able to understand the molecular landscape of HCC pretty well. In addition to these mutations, we know that which genes are frequently deleted or amplified. We know which molecular pathways are activated, and we also know the status of methylomics, or which promoters of the genes are hypermethylated, meaning that their function is suppressed. And this has resulted in our understanding of really what are the major downstream effectors that are controlling the growth and survival of liver cancer. And as you can see, one of the major drivers of this process is the receptor tyrosine kinase, RAS PI3 kinase pathway. About 20 to 25% of the cancers are showing activation of liver cancer, are showing the activation of this pathway. No wonder some of the first drugs that have been used successfully in treating liver cancer, including sorafenib, lenvatinib, rego, ramo, and cabo, which again, you'll be hearing more about later from Dulab, are all targeting this particular area of molecular pathways. However, there are other pathways such as telomerase, P53, Wnt, and certain chromatin modifiers, which are again present in significant subset of liver cancer patients, but unfortunately have not been yet successfully targeted. And there's a lot of ongoing research that is playing an important, that is hopefully going to make relevant progress, and we'll have better therapies in this space. But one thing that is very relevant and worth mentioning is because, again, liver cancer happening in chronic liver injury, there's always a very close relationship of immune cells or inflammatory cells that is observed in HCC. In fact, in this particular study, if you look at the tumor microenvironment, you see these cells, CD3, CD8 lymphocytes, CD20, CD68 macrophages, are always present within this tumor microenvironment. And one of the things that these immune cells do is that they should be there to attack and kill cancer cells. But because they produce these potent cytokines like interleukins and TNFs, et cetera, which are usually known to be cytotoxic. So why then, despite the presence of these immune cells within tumor microenvironment, they have not been able to kill hepatocellular cancer on their own? The question is, do they have these cancer cells develop some type of a defense mechanism against immune cells? And the answer is that is exactly what has happened. There is a very well-defined immune cell evasion that occurs by these cancer cells. And not to belabor too much and go too much into the biology, I would just say that there is upregulation of certain ligands such as PD-L1 on cancer cells, which engage T cells to block their proliferation and inducing their exhaustion. Also, there are others like CTLA4, which can bind to the dendritic cells and then can block the activation of T cells. So there are these maladaptive, there's rather adaptive mechanisms that these cancer cells have developed that have eventually resulted in immune cells not being able to recognize them and kill them. And for that very reason, has been this major game-changing technologies and modalities that are being used in oncology clinic, and those are the immune checkpoint inhibitors, because these immune checkpoint inhibitors have been able to target these PD-L1s or program death ligand 1 or program direct 1 receptor or CTLA4, and they have now prevented immune cell exhaustion, have altered Treg activity to activate T cells, which can then turn on the cancer cells to kill them. And indeed, that's been the basis of why there has been very successful use of immune checkpoint inhibitors in HCC treatment. And again, I think Dulab is going to talk a lot about medical therapy, but these are just some of the examples: nivolumab, pembro, and most recently, a combination of atezo-bev, which has attained objective response rates of about 30% and really unheard complete responses in about 7 to 8% of all liver cancer patients. And more data is coming almost every few months on some of these clinical trials. But there is high likelihood, in my opinion, that these objective response rates would not exceed beyond a certain level unless we understand more the biology of cancer cells and then try to be very careful in selecting the right subset of liver cancer patients who may respond better. And just a couple slides on that. One of the mechanisms or pathways that has been shown to drive immune cell evasion is the Wnt beta-catenin pathway, which, as I've mentioned, is seen to be active in about 25% of liver cancer patients. And this is just an example of how, if beta-catenin is mutated in the cancer, you see it as a nuclear translocation. And if you look at these liver cancer, you see very few CD8 positive cells in the tumor microenvironment. So beta-catenin mutated cancers actually prevent immune cells from even being infiltrating into the tumor. So they almost form like a shield of some sort. So these tumors are really immune desert. And that's the reason why if you use an anti-PD-1 in a beta-catenin mutated cancer, you see no tumor survival benefit. Whereas if you treat anti-PD-1 with, if you treat cancers that are driven by a non-beta-catenin dependent signals, for example, in this case, it was a p53 loss and MYC-driven cancer. These tumors respond very well to anti-PD-1. And this is also seen in patients where there's always overrepresentation of beta-catenin mutated patients in the non-responders. So I think learning about biology of tumors will be important to either exclude cases or convert these cases from cold tumors to hot. So this is my summary slide. HCC is a growing problem despite successful HCV treatment due to increasing incidence of NASH and alcoholic liver disease. HCC from a management perspective is really two diseases, and hence it's a challenge to treat. And then one thing that is very relevant is that that liver cancer always happens in the background of chronic liver insult that happens over many, many years. And there is very important role of surveillance and early diagnosis, because that's where the surgeons can actually make a lot of difference in the treatment of these patients. And finally, a whole genome sequencing has allowed us to identify various molecular subclasses of these liver cancers that has allowed us to identify what drugs to give, but this is very much work in progress. And finally, the immune cell landscape of HCC needs to be worked in further detail so that we can identify the right patients to be treated by the right kind of immune checkpoint inhibitors. So I'll kind of stop here, and we'll be happy to take any questions, which can again be put in a chat box. So thank you. So we don't.
I don't see any questions in the chat box right now, but we encourage you to send questions along the way, and we'll be happy to answer those questions. Okay, so I think we can move on to our next speaker.
All right, it's my pleasure to introduce our next speaker, Dr. Obaid Sheikh, who is a professor of medicine within the Division of Gastroenterology, Hepatology, and Nutrition. He's at the UPMC and also part of the VA health system. Dr. Sheikh has been in this business for quite a few years. After his initial training from Pakistan, he did his fellowship in hepatology at University of Southern California, and then since 1996 has been in Pittsburgh. He's done really seminal work in understanding hepatitis C. He's been involved in many clinical trials, especially in the area of acute liver failure and acetaminophen overdose, and has also now been involved in leadership roles at American Association of Study of Liver Disease and running many clinical trials here at UPMC. So I had requested him to talk to us today about risk factors and surveillance for hepatocellular carcinoma, especially providing a very relevant role of hepatologists in taking care of these HCC patients. So Obaid, welcome. Thanks for doing this, and looking forward to your talk.
Thank you, Paul. Next slide, please. Ed. Okay, unfortunately, I couldn't share my screen, so Ed has kindly agreed to move the slides.
You are on a presenter, not on a presenter mode. Is there a way we can? Okay, sorry. Thank you.
Okay, so Paul actually provided a nice segue into this talk. I'm going to talk about. So this is the overview of the talk. I'm first going to talk about the risk factors and disease modifiers which are associated with hepatocellular carcinoma. Next, I'll look at the strategies to decrease the risk of HCC development. And finally, I'll talk about surveillance for HCC in high-risk groups. Next slide. So let's take on risk factors and disease modifiers associated with HCC. Next slide. So any chronic GI tissue injury leads to inflammation and or fibrosis, and that increases the risk of cancer. And this is not particularly specific for the GI tract, but if we just focus on so it can happen in other organ systems as well. But looking at the GI tract, for example, in esophagus, if there is long history of acid reflux, and there is Barrett's development, that provides the environment for development of esophageal cancer. Similarly, in the stomach, if there is atrophic gastritis or focal intestinal metaplasia, that creates a risk for gastric cancer development. In chronic pancreatitis, particularly chronic calcific pancreatitis, there is risk of pancreatic cancer. Inflammation of the biliary tree is manifested as primary sclerosing cholangitis, creates a risk for development of cholangiocarcinoma. Patients with long-standing celiac disease have risk for small bowel adenocarcinoma. And similarly, those with ulcerative colitis have risk of colon cancer. So there is a pattern of moving from chronic injury to inflammation and fibrosis that leads to an environment which is conducive for carcinogenesis. So in liver, if there is chronic inflammation or chronic hepatitis, particularly if there is significant fibrosis associated with it, that creates a risk for hepatocellular carcinoma. Next slide. So let's look, for example, at hepatitis B. Hepatitis B is actually the most important cause of liver cancer worldwide. So if you look at the top figure there, the dark areas are the ones where there is highest incidence of chronic hepatitis B infection. And those are basically China and sub-Saharan Africa, and also Alaska. And if you look at the bottom figure, you can sort of overlap it. The bottom figure shows about hepatocellular carcinoma incidence. So there is a strong correlation between incidence of chronic hepatitis B and the incidence of hepatocellular carcinoma, which sort of, gives you an idea about the linkage between the two. Next slide. Now, hepatitis C is the second leading cause of hepatocellular carcinoma worldwide. If you go from the top to the bottom on the figure on the right, patients who are exposed to hepatitis C, about 75 to 80% will develop chronic infection. Over a period of 2 to 3 decades, 10 to 20% end up developing cirrhosis. And those are the patients, not only those with cirrhosis, but those who have extensive fibrosis, what we refer to as bridging fibrosis, they are at risk of hepatocellular carcinoma. And that is estimated to be at the rate of 1 to 4% per year. Next slide. Now, more recently, we have seen NASH emerging as the most important risk factor for hepatocellular carcinoma. So again, it's the same pattern of chronic injury. So moving from NASH, meaning there is fatty infiltration with some inflammation. So there is healthy liver to non-alcoholic fatty liver at the top. You can see that. To the right, there is non-alcoholic steatohepatitis, which means not only there is fatty infiltration, there is inflammation associated with it. Then this progresses to NASH with fibrosis, cirrhosis, and that provides risk for hepatocellular carcinoma. Next slide. So the risk of hepatocellular carcinoma may vary by etiology of liver disease. As I mentioned earlier, chronic hepatitis C and B were noted to be the most important causes for chronic liver disease and hepatocellular carcinoma risk in the US. Now, more recent studies, so this figure on the right is from the Veteran Health Administration, from the national database. As you can see, the patients with NAFLD are at much higher risk of hepatocellular carcinoma compared to controls. Next slide. So there are multiple disease modifiers that impact HCC development. So I already mentioned cirrhosis and advanced fibrosis, but in addition to that, there are other disease modifiers, including race and ethnicity, smoking, alcohol use, viral load in the case of hepatitis B, obesity and diabetes, insulin resistance, gut dysbiosis, and inflammation. Next slide. Cirrhosis is the most important risk factor for HCC. So if you look at the figure on the left, and you see these trend lines indicating cumulative risk with months of follow-up. So with time, the risk of development of cumulative risk of development of HCC is highest in patients with cirrhosis. In this particular study, there was a combination of those with cirrhosis and elevated alpha-fetoprotein level were at the highest risk, which is not surprising. While those with just chronic hepatitis had a much lower risk. So indicative of liver cirrhosis being the most important risk factor for HCC. However, there are patients who may develop HCC without cirrhosis. So on the right is a study that compares patients who have hepatitis C on the left to those with NASH on the right. And as you can see, in patients with hepatitis C, less than 10% of the patients who have HCC, they don't have cirrhosis. So cirrhosis in hepatocellular carcinoma in patients with hepatitis C develop in 10% of the cases, there is no associated cirrhosis. But when you compare to patients with NASH, there are almost 20 to 25% of the patients with hepatocellular carcinoma who don't have cirrhosis. So cirrhosis is obviously a very important risk factor for HCC, but there are patients without cirrhosis, particularly in NASH, who may develop hepatocellular carcinoma. Next slide. Race and ethnicity is also an important risk factor. So this slide shows the trend in HCC incidence between 2000 and 2012. So at the top are the Asian Pacific group that has the highest risk of hepatocellular carcinoma, followed by Hispanics. Next slide. Now, how about viral load? Now, this was particularly demonstrated in chronic hepatitis B. So these are, on the left, are all patients. The lines actually show you different groups of patients with different level of viral load. And this, with time, it shows you the cumulative incidence of HCC. As you can see, the top line, the dark black line, are the patients who had greater than 1 million copies of HBV DNA in their blood. And the bottom lines actually show you those with a lesser degree of HBV DNA level. And as you can see, those with the highest level of HBV DNA were at the highest cumulative incidence of HCC. Now, on the right, if this is the subgroup of patients who were not cirrhotic, they have normal ALT, and they were HBe antigen negative. Now, the significance of HBe antigen is that in negativity, it usually indicates a quiescent disease. However, there is a subgroup of patients who may have high DNA level who are HBe antigen negative, and they have a sort of a mutation in hepatitis B that causes E antigen negativity. So even in this subgroup of patients, those with the highest level of DNA level had the highest risk of hepatocellular carcinoma. So this slide, actually, this study showed the association between viral load and risk of HCC. Next slide, please. Now, how about alcohol and smoking? So in the left is a study that looked at 5-year cumulative incidence rate of HCC according to alcohol intake and viral eradication. The top line are those who were drinking alcohol and had HCV eradication. And the bottom line are the ones who were not drinking alcohol and also had HCV eradication. And as you can see, there is a significant difference in the cumulative rate of HCC between those two groups, indicating that alcohol can independently increase the risk of HCC development. And these are patients who had underlying cirrhosis. And similarly, this again shows another study, the risk of HCC according to the cumulative alcohol consumption in terms of grams per year. And the odd ratio of HCC development is higher among those with a higher level of alcohol consumption. And the same applies to tobacco consumption in terms of pack years. So both alcohol and tobacco increase the risk of HCC development. Next slide, please. Now, how about obesity? This has been shown to be a risk factor of HCC. And so in this study, if you, there is different age groups, you can see overweight, obese. And if you look at the cases on the left, compare it to the controls on the right, those with obesity, the bars are much longer compared to the controls, indicating obesity as a risk factor for HCC. Next slide, please. So this is all within the group of patients who have metabolic syndrome. Metabolic syndrome is the combination of obesity, insulin resistance as manifested with type 2 diabetes, dyslipidemia, and hypertension. So this is a study looking at HOMA2IR, which is a measure of insulin resistance. And as you can see, on the left are patients with hepatitis B, and this shows the cumulative incidence of hepatocellular carcinoma. So those with a higher level of insulin resistance had higher risk of HCC. This also applies to patients with hepatitis C on the right. Again, if you look at patients who developed hepatocellular carcinoma, they had a much higher level of HOMA2-IR with a cutoff greater than 4, indicating insulin resistance being a risk factor for ACC in both patients with hepatitis B and HCV. Next slide. How about gut microbiota? And this has emerged as an important risk factor. This is an association between gut microbiota that is measured by Simpson's Index of Diversity. So on the left side, you can see the extreme left figure, there are healthy controls and cirrhosis. So there is a difference in diversity with a lower diversity index in patients with cirrhosis. On the right, you can see the patients with in yellow who are the healthy controls, green cirrhosis with no hepatocellular carcinoma, and red cirrhosis with hepatocellular carcinoma. And as you can see, there is a difference in diversity with lowest diversity among patients with cirrhosis and hepatocellular carcinoma. Next slide, please. Let's talk about strategies to decrease the risk of ACC development. Next slide. So as Dr. Monga indicated, you have normal, if you look at the top bar, normal hepatocyte moving along with subclinical molecular histological neoplasia. Then you have diagnosis of primary ACC, and then there is secondary ACC. And this correlates with liver disease progression from chronic hepatitis, advanced fibrosis, and cirrhosis. So the question is, what sort of strategies we can apply to prevent ACC development at different stages of the disease process? So the primary prevention would be before chronic hepatitis actually develops. Secondary, when there is chronic hepatitis, advanced fibrosis and cirrhosis, and perhaps there is early development of HCC. And tertiary, once the patient has already developed HCC, treated, and what sort of strategies we can follow to prevent further development, recurrence, or new ACC development. So the number of strategies which can potentially be applied, antiviral therapies, anti-inflammatory treatments, anti-fibrotic treatments, metabolic disease treatment, and molecular targeted therapies. Next slide. So in terms of primary prevention, this is for individuals, healthy individuals who have not yet developed liver disease. What can be done? So one of the preventive modalities that have been looked at is just diet. And as you can see, when you move from vegetable diet to animal fat, dairy fat, and combination of animal and dairy fat, the hazard ratio for ACC development goes up. So there is merit in limiting the amount of animal and dairy fat. Next slide. This is the Alternative Health Eating Index. And as you can see on the right is the highest quality diet, and that is associated with lower ACC risk. And I mean, there is information available for Alternative Healthy Eating Index, and essentially lower added sugars, lower fat, more grains, legumes, nuts, etc. Next slide. Now, one of the greatest success in HCC prevention and control of hepatitis was observed in Taiwan. So Taiwan introduced hepatitis B vaccination in 1984. And over the years, I mean, this slide only goes up to 1993, but that led to a dramatic drop in HCC development and HCC death rates in children who are 0 to 9 years of age at the time of vaccination. Next slide. Secondary prevention in terms of those who already have hepatitis B. So if you treat hepatitis B, there is a lower risk for HCC development. This is again a study from Taiwan looking at almost 22,000 patients. The top line are the patients who were not treated for hepatitis B, the bottom line who underwent treatment for hepatitis B, and there is a significant difference in the cumulative incidence of HCC among patients who underwent treatment for hepatitis B. So suppression of virus or viral eradication in hepatitis B reduces the risk of HCC. Next slide. And the same is true for hepatitis C. This is a study by Kamal et al. And actually, we were also involved in another study. I don't have the paper to show you, and with similar results. So this is a study of patients who had hepatitis C, who underwent treatment for hepatitis C. And unlike hepatitis B, in hepatitis C, we can actually achieve viral eradication. And as you can see, there is a significant difference in HCC incidence among patients who achieved a sustained virologic response compared to those who were unable to achieve a sustained virologic response. Next slide. So going back to the point about both hepatitis B or HCV, suppression. So first of all, there is a association between HBV viral level and HCV development. But if you treat or suppress HBV virus or you eradicate hepatitis C, both of those strategies result in reduction in HCC risk. Now, how about diabetes and alcohol? So this is a study looking at those patients who actually had a sustained virologic response to hepatitis C therapy. So hepatitis C, in a way, and looking at other factors that can influence risk of HCC in addition to hepatitis C. And as you can see, two factors actually stand out. One is diabetes and another is alcohol. So patients with diabetes and those with continued alcohol use had a higher risk of HCC development. Next slide. So how about, is there a prospect for chemoprevention in hepatitis C? Can we use something, can we give a medicine that will prevent the development of hepatitis C? And two drugs stand out. One group of drugs are statins, which are widely used, and the other is aspirin. Next slide, please. So there are multiple ongoing trials of HCC chemo prevention with a number of agents, including statins, vitamin D, herbal medications. Next slide. And this is a study from Swedish registry looking at 50,000 patients with hepatitis B and HCV. Patients who used aspirin low dose were at a lower risk for HCC. Next slide. This study looked at statins. So there are patients on the left with liver cirrhosis at the top line, those without liver cirrhosis on the right, and at the bottom are patients with diabetes and without diabetes. And as you can see, that the adjusted odds ratio for HCC was much lower in patients who ever used statins. So this points towards possible beneficial effect of a statin in prevention of HCC. Next slide. Similarly, metformin use has been associated with decreased risk of HCC. Next slide. Coffee consumption is associated with decreased risk. Next slide. Vitamin D levels, higher vitamin D levels have lower risk. Next slide. Okay, so I talked about multiple associations in terms of risk factor for ACC. Most of these are associations, and there are prospective studies probably needed to confirm those observations. So what are the strategies in terms of those who are at higher risk of ACC? What can we do in terms of early detection of ACC at a stage where we can make a difference in terms of their outcome? Next slide. So this study looked at this question, and it looks like that if we perform surveillance, it leads to early detection. This is a meta-analysis looking at a number of different studies. And it not only surveillance improves early detection, it can lead to a higher level of curative therapy, resulting in improved 3-year survival. Next slide. So in view of those findings, here are the AASLD guidelines for AC surveillance. Who should be screened for ACC? So patients with cirrhosis needs to be screened and should undergo surveillance for ACC. And there are a number of groups. Cirrhosis may be from hepatitis C, B, alcohol, NASH, primary biliary cirrhosis, hemochromatosis, and alpha-1 antitrypsin deficiency, or any other cause of cirrhosis. All those patients need to undergo surveillance for ACC. Now, how about patients who actually do not have cirrhosis, but they have significant risk factors for ACC development? So this group includes patients with hepatitis B, an Asian male older than 40 years, an Asian female older than 50 years, patients with hepatitis B at any age with family history of HCC, and Black and Africans with hepatitis B greater than 20 years. So these patients need to undergo surveillance in the absence of cirrhosis. That is, with or without cirrhosis. Next slide. What is the best strategy for HCC surveillance? This is a meta-analysis looking at 13,000 patients. So if we use ultrasound alone, the sensitivity is 45%. When we combine it with ultrasound and alpha-fetoprotein level, the sensitivity improves to 63%. Next slide. Once we could use ultrasound, another modality we often use is either an ultrasound-based. This is from the LERADS classification of liver nodules. When you look at liver nodules, there are certain features of liver nodules on ultrasound, as well as on CT and MRI. And based on those findings, you can determine whether it's a definite HCC, which we term as LERADS 5, or those with indeterminate or benign lesions. Next slide, please. We have to be conscious about harms with surveillance strategies, because if we see a nodule, we think it's HCC, then it creates a chain of events, may lead to biopsy. Biopsy can cause complications, may even have death. So we have to be conscious about the fact that the question is, can HCC surveillance cause harm to patients? So what it makes us think is that perhaps we need to have better modalities for HCC surveillance. We're using ultrasound and alpha-fetoprotein, but as I showed you, the sensitivity is 63%. And then there are patients with false positives who undergo further treatment and interventions, which can cause potential harm. Next slide. So this will be the future. We need newer biomarkers for HCC surveillance. We need deep learning based on MRI images, and clinical data are being developed to improve our surveillance results. Next slide. So in conclusion, cirrhosis from any cause and chronic HBV infection without cirrhosis are the most important risk factors for hepatocellular carcinoma. There are potentially modifiable risk factors that can decrease the risk of HCC development. Chemoprevention of HCC may help decrease the risk of HCC in high-risk subgroups. Currently, ultrasound with alpha-fetoprotein every 6 months is the preferred surveillance method for HCC, but better surveillance strategies are needed. Thank you.
Thank you.
Thank you, Wade. That was fantastic. Really appreciate it. I'm hoping that there are going to be questions in the chat, but in the meantime, I think we have a few questions. I was just wondering, Wade, if the obesity as a risk factor for HCC, do you think it's because of underlying NASH or obesity just being a general pathology which is inflammation prone? These anytime you have obesity, you have altered levels of inflammatory cytokines. So it's a underlying inflammation that's present. So you think it's mostly inflammation, or is it NASH that is associated as a risk factor?
So I think NASH is probably the most important risk factor for HCC development. And as I shown in one of the slides, that NASH, even without cirrhosis, can lead to HCC. But I think you're right. Obesity itself is probably an independent risk factor because of the lipotoxicity it triggers.
That's right. And my last question is about, you showed very nicely the decrease in diversity, gut microbiome diversity from healthy controls to cirrhosis, and further decrease in diversity when it comes to cirrhosis with HCC. Do you think it's the cause of HCC, or is it an effect of HCC? That these are really correlation studies, right? Have people done alterations where they have done fecal microbiota transplants, for example, especially in preclinical models, to see if that can affect the biology of the disease?
Yeah, I think you're right. I mean, these are associations. I think there are studies underway in animal models to looking at this. For human studies, it will take a long time because, as you know, HCC takes a long time to develop. And
that's right.
Observation is going to be very tricky to study.
Okay, great. Well, thank you, Obaid. That was really very nice. I really appreciate your time. And it's now my pleasure to introduce our next speaker, Dr. David Geller. Dr. Geller is a professor of surgery at the University of Pittsburgh School of Medicine. He's also the director of the UPMC Liver Cancer Center. And his clinical expertise has been in performing laparoscopic liver resections and laparoscopic radiofrequency ablations of liver tumors. He's very well recognized and well-respected physician and a scientist. He has over 320 scientific papers and chapters, and a member of many societies, including Society of Surgical Oncology, Society of University of Surgeons, and American Society of Transplant Surgeons. He's also involved with our Pittsburgh Liver Research Center, where he's the director of one of our biospecimen course. So Dave, really excited to hear your talk on surgical resection and liver transplant for HCC. Welcome.
Thank you very much. Can you guys hear me okay?
Yes.
Okay, perfect. The decision-making in clinical management of liver cancer depends on several features, whether the tumor is primary or metastatic. This talk will focus on hepatocellular carcinoma. Synonyms are primary liver cancer, HCC, or hepatoma in the literature. But just so that you know, the overall most common cancer we see in the liver is not primary liver cancer, but it's stage 4 metastatic colorectal cancer, because there's 160,000 cases of colorectal cancer each year, and just over half, about 60%, will metastasize to the liver. But we're going to focus, because this conference, on HCC. When you're dealing with HCC, as we've already heard, it depends upon the size, location, number of tumors, whether there's vascular invasion, whether it's spread outside the liver, and about 85% of the time, the HCC occurs because the background liver is cirrhotic, and we have Child's classification where A is the least damaged liver and C is the worst. The take-home message for this lecture is that liver resection or liver transplantation, most commonly for stage 2 HCC, remains the gold standard and provides the best chance for cure or long-term survival. Before we get into specifics, this is what a normal liver looks like, and large tumors can be cut out of the liver. Here you can see this was not HCC, but colorectal mets. We removed a large tumor from the right lobe and most of the left lobe, and we preserved about 25% of the liver here, and that's just enough for the patient to function and survive. And even basketball-sized tumors can be removed. Dr. Paul Monga mentioned in his talk about the rare fibrolamellar variant. We had a young 29-year-old male that's in the hospital upstairs and literally had a 20-centimeter tumor that weighed over 15 pounds. That was a fibrolamellar HCC that we just resected on Tuesday, and he should be able to go home hopefully tomorrow. Our liver cancer and transplant service started in Pittsburgh in year 1981 when Dr. Starzl came from the University of Colorado to Pittsburgh. Here's our Cathedral of Learning. And Dr. Starzl passed away about 3 years ago, sadly, just prior to his 90th birthday. But his influence was so important that Pittsburgh Magazine 3 times made him Man of the Year. And even for those who love our beloved hockey fans, when they won back-to-back Stanley Cups in 90, 91, and Mario Lemieux got Hodgkin's lymphoma and beat it. And the byline was Mario's courageous return, but yet Dr. Starzl still got the cover, and Mario got only the background story, which shows you the importance of Dr. Starzl and his influence in the Pittsburgh region and the entire globe for that matter. So I won't belabor the statistics. You've heard them, about 40,000 cases. One of the slides shows that 42,000 last year, rising in cirrhotic, 3 to 5% per year. Hep C, which is fading, alcoholism, and the explosion of fatty liver disease are the major risk factors. And we've already said the only chance to cure it is to cut it out or switch the livers with liver transplant. Some of you may be wondering, well, how many liver transplants have been done or are done in the United States? So the data is on a national database called OPTN, which has the government contract. And you could just Google OPTN and then pull up all this data. It's widely available. There's 189,000 cases of liver transplant have been done since we started recording it in year 1988. And for 10 years, statistics were humbling. From 2007 and prior to that to 13, it was only a little over 6,000 liver transplants per year. And we've made pretty nice headway in the last 7 years, where you can see a rise in the curve to now the last 2 years, 2019-20, nearly 9,000 liver transplants. So in part, that's better organ donor awareness and people giving either self-donating their livers on their driver's license or the family members graciously donating to save lives. How good are we at liver transplantation? Here, the most recent data from the government website, OPTN, 1, 3, and 5 year survivals for all liver transplant recipients in the USA, 91% 1 year, 83% 3, 75%. What about if we subset out those who actually had a liver transplant for hepatocellular carcinoma? It's nearly identical. 1 year the same, a little bit less at 3 year 80 and 5 year 70%. And these were liver transplants done between the years 2008 and 15, so pretty modern cohort to give us the 5 year follow-up. Nonetheless, we still have a critical shortage of organ donors in the USA. As of this website is updated every 2 weeks. So this was a week ago, October 21st. There are 11,722 patients on the wait list in the United States, but yet, so 11,700 waiting, but last year we only had 8,900 liver transplants. So we're about 3,000 livers short. And you could say, well, what about if we do more living donors? Well, in year 2020, only 491 living donors were done in the United States. The vast majority were a deceased donor. So the living donors only account for 6% of the total number of transplants. So most people need to wait for a cadaveric donor from someone who passes away from either a car accident or a stroke, and then the family donates. What are the consequences of being 3,000 livers short per year? Well, last year, 1,078 patients died over the year. So that's about 3 patients per year, 3 patients per day die waiting, and another 3 to 4 were removed because they were too sick. So we really do have a organ donor crisis, and patients are dying while they're waiting on the list. You might be wondering, well, what's the landscape in Pittsburgh? So these are the statistics right from the website. How many liver transplants were done last year in 2020 in Pittsburgh? Well, UPMC Presby, 149 liver transplants were done. And note, it's Dr. Humar, who's our chief of liver transplant, specializes in live donor. More live donors were done than deceased donors. About 60% of the total liver transplants were live donor, 91. Children's Hospital did 32 liver transplants last year. AGH did 42, and the VA did 37. So in the Pittsburgh region, with 4 programs, we've had 260 liver transplants per year. To put that in perspective, when I was an intern here back in 1988, and the second year was in 89, we did 550 and 600 at a combination of Presby Children's and the VA. AGH didn't have a program back then. And the reason the numbers have gone down is because back then there were not as many programs, but now nearly every university has a liver transplant program. There's approximately 120 liver transplant centers in the United States. So there's intense competition for the donors, but 260 is still a good number for the Pittsburgh region. How about the cancer outcomes with the open liver resection for HCC and comparing it to laparoscopic? Here's the data showing 5-year overall survival in comparative studies of lap liver resection, LLR, versus open liver resection for HCC. These are the 2 columns. 5-year survival. And one of the criticisms when we started doing minimally invasive liver resections, you would be compromising outcomes, but the data hasn't shown that. From 2001 to 2016, there were 978 lap livers compared to 1,400 open liver resections, and not a single study showed any difference. So NS means not significantly different. 5-year survivals in the 50 to 60% range for either lap or open liver resection. And the data together shows that lap liver resection has comparable 5-year overall survival versus open liver resection for hepatocellular carcinoma. This is one of the biggest studies of propensity score match, which means the tightest matching of 31 centers in Japan. The patients were well matched for gender, child score, liver function, which is ICG clearance, presence of hepatitis, tumor size, number, location, extent of resection, 387 patients in each group, and the survival curves were nearly superimposable, equal survival in lap versus open liver resection. This is the only randomized clinical trial that's been done in the field for HCC. It was a small study comparing child's age 25 lap to 25 open. The study was done in Egypt, so we applaud them for doing that. The lap liver resection had shorter OR time, shorter length of stay, less narcotic use, and a quicker time to diet versus open liver, but no difference in blood loss, transfusions, margin negative rate, overall complications, or 3-year midterm survival rate. So it shows there are benefits to lap liver resection. Positive randomized clinical trial in favor of lap because of the clinical benefits, but same cancer outcomes. Here's a series with Pittsburgh and others put together looking at nearly 10,000 cases of laparoscopic liver resection. 2/3 were done for cancer. And in those cases done for cancer, HCC, 50% of the cases are for HCC, 26% for metastatic colorectal cancer. Mortality was less than 0.5%. Lap liver resection had better clinical outcomes, less complications, less blood loss, less transfusions, shorter length of stay versus open liver resection in a meta-analysis of nearly 3,000 of these cases. Here's an example. Some of you may wonder, what does cirrhosis look like? I showed you earlier that smooth brown liver. This is what cirrhosis looks like. The liver is bumpy, it's rock hard. There's a massive portal hypertension, recanalized umbilical vein. These are collaterals or varices. Here's a small HCC tumor in a 78-year-old man. If we open this person for open liver surgery, he would probably decompensate because you would get massive ascites, you could get variceal bleeding. So the key is to stay laparoscopic, and going in, here's what the HCC looks like. It's white, yellowish in color. It's soft or fleshy. It's not rock hard like colon adenocarcinoma. It's easy to rupture, and we get 5 to 10 of these a year coming in with spontaneous rupture. And here's a picture with the completely resected laparoscopically, where we don't decompensate the liver because we don't interrupt any of these varices. And that's what the cancer looks like resected. And this is the picture of laparoscopic, just like laparoscopic gallbladder surgery, even in more advanced cirrhosis, the patients tolerate this. As I'll show here, here are about 8 papers published looking at couldn't we now extend from Child's A to Child's B cirrhotics. We published a paper in 2018 looking at our series at 26 cases, and there were a smaller series, and then there's a large series that was just published this year in British Journal of Surgery from Roberto Trossi and the team, looking at international study in 17 centers. UPMC was one of them. There were 382 livers, 160 lap versus 222 open for HCC, all Child's B cirrhotics, and then a subset of propensity score matching 100 to 100. The lap liver resection had less blood loss transfusion, post-op ascites decompensation, less morbidity, less major complications, and shorter length of stay. No difference in R0 negative margin rate, both 95 versus 6, and long-term survival was comparable, maybe even a little bit better, but not statistically, trended towards 65% 5-year survival lap versus 47% open. How about our performance? We looked recently at our performance in 1,000 minimally invasive laparoscopic liver resections published last year in JAMA Surgery, and we divided into 3 periods: our first 200 cases from 2001 to 7, our next 400, and our subsequent 400. And what the data shows in this table, comparing periods 1 to period 2 to period 3, we got better. The parameters improved. OR time shortened, transfusions decreased. The percent of cases that were pure lap were almost 3/4. The complication rate decreased from period 1 of 15 to 5% in periods 2 and 3. More background cirrhosis we could tackle. The percentage of total lap versus total cases compared to open increased to about 1/3 of our cases are no laparoscopic, and our conversions remain low in all 3 time points. So it shows that laparoscopic liver resection indeed has patient benefits, and you could take on more challenging cases without having decompensation. Our next talk will be, the next speaker is going to talk about regional liver therapy. So I'll just have 2 or 3 slides to introduce the topic. Here's an Asian woman with hepatitis and a massive hepatocellular carcinoma, AFP over 12,000 here, got some regional liver therapy, transarterial chemoembolization, initials are TACE. For 12 cycles, the tumor melted away, the alpha-fetoprotein normalized, and she lived for many years after these regional therapies. Sometimes we can even use the regional liver therapies as a bridge to resection or transplant. Here's a large left lobe hepatocellular carcinoma. Back in 2003, the FP was 31,000 and got regional therapy ×4, and the tumor shrunk down now to just over 50% shrinkage to this tumor. Then we were able to go in and resect the patient. The AFP hadn't normalized, it was still nearly 800, and after resection, we normalized the patient and give the patient a chance for cure. 1 year out, the patient was disease-free. We'll hear more in the next talk, I'm sure, about internal radiation called Y. Y stands for yttrium. Yttrium 90 is Therasphere. It's a beta emitter with a short half-life, and it penetrates about an inch or so, a few centimeters in the liver. And this is good for, in addition to regional therapy, for regional liver therapy. Here's an example of a patient on angiogram. You see 3 tumor blushes, which means cancer. 1, 2, 3. After radiation beads injection, the HCC is gone or wiped out. So another option for regional liver therapy. Let me summarize by saying, when we identify HCC, what do we do in the clinic? And so this is what the thoughts go through our mind. The first question you should ask is the patient now, or will they ever be a resection candidate? And so if you can resect them in non-cirrhotic or early Child's A single lesion, then they should get the resection. That gives them the best chance for cure. But if they're not a resection candidate, then the next question to ask is, are they a liver transplant candidate? And the rules in the USA are that a stage 2 tumor, stage 2 HCC means 1 tumor up to 5 centimeters, 3 lesions up to 3 centimeters. So you can have a 1 centimeter, a 2, and a 2. That would be a stage 2, and they can get on the transplant list. And after 6 months on the list, they can get bonus points. The stage 1s, which means a single tumor under 2 centimeters. So if it's a 1 centimeter tumor, it's an early stage 1 liver cancer. They don't get bonus points. And you can have vascular invasion or spread outside the liver. Then they could be a transplant. If they have a living donor, then they get worked up, which takes about a month. And then a suitable donor, they can go on the list. If they don't have a live donor, you have to ask how long is the wait list going to be? Because in some states, the wait list or regions of the United States, it might be anywhere from only 3-month wait list versus some states with intense competition, the wait list could be 2 years. And in Pittsburgh, if you're a blood type O, which is the most common, and you get on the list, it could be a 1 to 2 year wait. So we tend to bridge them with neoadjuvant therapies, laparoscopic, radiofrequency, microwave ablation, chemoembolization, or yttrium, sometimes even medical therapies, and hopefully to get the liver transplant. We're going to hear a little bit later when they're not a transplant resection or regional liver therapy candidate, then there's many systemic and immunotherapies. We'll hear all about this from Dr. Dulab Manga, so I look forward to that update. But 10 years ago, all we had was sorafenib. Maybe 12 years ago, the SHARP trial approved that. So we've come a long way for regional therapies, and now we're combining these with systemic and immune therapies, combined with regional liver therapies. We're even talking about using some of these as a bridge to transplant. So the data keeps evolving. It's an exciting time to be involved in multidisciplinary teams managing hepatocellular carcinoma. I will conclude by saying that surgical resection or liver transplants the only chance to cure HCC. For those who are not cured, we can often extend years of life. Laparoscopic liver resection for HCC has been performed in thousands of patients worldwide with comparable oncologic outcomes and clinical benefits with less decompensation, and they can be done in selected Child's B cirrhotics. Multiple regional and systemic chemo and immunotherapy options exist. So that concludes the talk, and thank you very much. I'll be happy to answer any questions if there are any.
Thank you, Dave. That was phenomenal. I think learned a lot about the current state of both the resection and the transplant, and even you touched upon some local regional therapies. So the audience has been rather passive this time around. So we have not had any questions, but Dulab has a question.
So thank you, Dave. That was a great talk. Always nice to see wonderful outcomes with minimally invasive surgery. But one of my questions is for smaller tumors less than 5 centimeters, what is the difference between doing a resection versus taking a patient to transplant? Is there any difference in outcomes?
The subset of patients that can be eligible for either resection or transplant is actually smaller than you think. For example, if there's a 3 centimeter tumor deep in the liver, and it might require right lobectomy, that cirrhotic patients, they don't usually tolerate that. So and because of the organ donor shortage in Europe and the USA, it's pretty bad. And in Asia, it's severe because even though brain death is allowed, the cultures haven't accepted it. So if you look in Asia, most of the liver transplants are done with living donor. So in general, if the tumor is resectable, we resect them. But if you take most Child's A cirrhotics with stage 2 HCC, most of those we have to bridge them, and the 5-year survivals are probably a little bit better with liver transplant. So in my opinion, if it's a cirrhotic with stage 2 HCC, the best treatment is liver transplant, and 5-year survivals there are in the 75% range, as we showed earlier in the talk. But if you look at all patients who are resected, because they have cirrhosis, the majority recur. There's about a 60 to 65% recurrence rate. So the cure rate is probably only about 50% for resection, but 75% transplant. So to me, if there's a cirrhotic and there's a stage 2 HCC, the gold standard is get them on the liver transplant list. And if you can't have a live donor, then we have to bridge them to transplant. And in spite of our best efforts, you can see my earlier slides, there's drop off. Patients die waiting on the list, and in spite of our best efforts. So it shows you that we need more organ donors, and we need better regional therapies to buy time.
Thank you. The other question I had was, if a patient is infected with either hepatitis B virus or hepatitis C virus and is a transplant candidate, in the waiting period, are we treating them actively with the treatment, or being infected or having, active hepatitis B or C may give them a higher chance of getting a liver from an infected individual rather than a healthier donor? Is there such a thing?
Yes, the excellent question. And I'm going to focus the answer on Hep C, because in the USA, Hep B is, in general, if a person has Hep B, we treat them, and the treatments for Hep B are excellent. When I was a transplant fellow and young attending a million years ago, Hep C was the number one reason for liver transplant in the USA, and we would treat the Hep C prior to liver transplant. But now the algorithm has shifted, because we still have some Hep C donors, and because the acting antivirals are so good that if they have Hep C, typically now we'll try and get them a transplant and would not treat them, use a Hep C donor, and then knowing that we can eradicate the Hep C after transplant with over 95% efficacy. And that gives them a chance to get a Hep C liver. That strategy is because we're so good at eradicating Hep C. Now there are studies showing you can even put a Hep C into a naive non-viral hepatitis recipient and then treat them after as a way of getting them transplanted, especially if they've got a stage 2 HCC that might kill them before their liver disease does. So in the old days, we used to treat the Hep C first. Now most centers are being selective and saying, no, let's keep your Hep C as is and see if we can get you an organ donor quicker, and then we will treat you afterwards. So it's a major shift, and that shift happened probably, I'd say, 3 or 4 years ago.
Great, thank you.
So Dave, I had a question. Is there any role of immune checkpoint inhibitors in a neoadjuvant setting for resection and or for transplant?
Okay, so let me start with the transplant first. Mm-hmm. When you're on immunotherapy, it boosts your immune system, and there's a great fear that this could then lead to rejection, because yes, if you have a living donor, you schedule it, but if you're waiting on the list, like 95% of patients need to do, your transplant could be tomorrow, and then you don't have time to stop the immunotherapy, and then the risk is that then you get your transplant and you'd have early acute cellular rejection. So in general, people have shied away from it. However, anecdotally, there's just some data coming out. Mount Sinai just did a study on papers under review where it's been their experience that they do not see rejection for those patients that got immunotherapy and then got a cadaveric liver transplant. So I think that this field is evolving, and we're going to see some interesting data. But in general, there's been a great fear either before or after liver transplant of using immunotherapy for the risk of inducing rejection.
Right. And in the setting of resection, I think it's relatively straightforward, right?
Yes. In the setting of resection, if you can resect them, we do. There's no evidence of adjuvant. If you resect it to HCC with negative margin, there's no proof that chemo or immunotherapy can help, but those options get activated when they recur and they're not operable.
Mm-hmm.
Right.
Okay,
awesome.
Wonderful. Thank you, Dave.
Thank you very much.
Okay, so we have our next speaker, Dr. Andrew Klabuka. It is an honor to introduce him. Dr. Klabuka received his degree from Drexel University College of Medicine in Philadelphia. He subsequently completed his clinical internship and radiology residency at the University of Pittsburgh Medical Center, where he served as chief resident before completing a fellowship in vascular and interventional radiology at Allegheny Health Network. He's currently a practicing interventional radiologist at Allegheny Health Network, based out of Allegheny General, West Penn Hospital, and Forbes Hospital. He serves as the radiology lead for the Allegheny Health Network Liver Tumor Board and has a particular interest in minimally invasive interventional therapies for HCC, as well as hepatic metastases for colorectal and neuroendocrine tumors. So Dr. Klubuka is going to talk today about role of local regional therapies in HCC management. Dr. Klubuka?
Thank you, Dulab and Paul. I do appreciate your invitation to speak today. It's my pleasure to be here. I don't have any disclosures relevant to our discussion. What I do have, however, is the task of covering all of local regional therapy in 30 minutes. So we're just going to get right to it. So I'd like to begin with a brief review of the National Comprehensive Cancer Center guidelines as pertinent to HCC via the 2021 updates. And so in my mind, I like to think about these as being patients stratified based on whether or not they're transplantable or resectable. Let's begin with those who are potentially operable by performance status or comorbidity. As Dr. Geller described previously, we do additional stratification based on Child-Pugh classification and the presence or absence of portal hypertension. And then if resectable, that is, of course, the preferred treatment as he described. However, local regional therapy, specifically ablation, is an alternative in this specific group of patients. Moving on to those who are unresectable, either due to inadequate hepatic reserve or tumor location, we of course do the transplant evaluation. For those who are unfortunately not transplant candidates, again, we kind of come to local regional therapy, including both ablation and arterially directed therapies as primary treatment modalities. And for those patients who kind of correlate to the BCLC advanced stages, those with liver confined disease, but who are inoperable with poor performance status, multiple comorbidities, or even those with minimal or perhaps uncertain extrahepatic disease. Again, we see that local regional therapies, including ablation and arterially directed therapies, are going to be the hallmark of treatment. And so I'd like to come back to the BCLC, which I was referring to. This is an updated version from 2021. And you can see how they substratify these patients and kind of divide the treatment algorithm based on staging, which kind of comes down to a few factors, including the number and size of the HCC lesions, the Child-Pugh status, as well as the performance status. The left side of the chart being those who are potentially curative via ablation, resection, or transplantation. In the intermediate stage where you reach multinodular disease, chemoembolization, and I would add radioembolization is another option before you reach advanced stage where you're looking more at systemic therapies. And as you can see too, the overall survival is best at the left side of the chart and decreases as you reach terminal stage. Now, for me as an interventional radiologist, I'd like to simplify this into early, intermediate, and end stage. And so when we talk first about the early stages, those who are potentially curable, let's talk about ablation as an alternative to surgery. So percutaneous ablation offers a high probability of complete response for lesions less than 3 centimeters, looking at 85 to 95% rates of complete necrosis. Contrary to some prior concerns about tumor dissemination, the probability of dissemination via percutaneous access and approach is kind of case reportable. And of course, there's less morbidity than surgical resection given the percutaneous techniques. Just a quick example here, you see in the top left panel a hypervascular hepatocellular carcinoma. You see that it's focally hypoechoic on ultrasound, and you can use either ultrasound or CT guidance to place probes, either radiofrequency or microwave, bracketing the lesion, which will then deposit thermal energy to result in tumor destruction. And the final panel here, of course, is showing kind of a post-ablation treatment zone with a scar and no viable tumor remaining. So what's new in the field of radiofrequency ablation and percutaneous techniques? Well, we do have some newer devices, such as curved electrodes, which can help us navigate around areas which were previously considered to be not ablatable due to proximity to either critical structures or vascularity. In addition, we have directional microwave probes now that we can use. Just to give you a quick example, if you had a surface lesion like Dr. Geller showed in one of his laparoscopic images, to do ablation would be difficult because of kind of bleed through of the heat sink into adjacent structures such as diaphragm or colon. With a directional ablation probe, you can then place that probe on the surface and direct the area of ablation specifically away from any danger or critical areas, which you can kind of see graphically depicted in this ex vivo specimen. So coming back to the NCCN guidelines, again, I'm not going to read this, but I'm going to pull out what we talk about for the footnotes for ablation specifically. And so what they're saying is in a well-selected group of patients with small, properly located tumors, ablation should be considered as a possible definitive treatment in the context of a multidisciplinary review. So how do we break this down? Let's talk about those less than 3 centimeters. These are potentially curative if they're in a location amenable to ablation, knowing now that we have expanded options with their new tools. For those with 3 to 5 centimeter lesions, combination of ablation and arterially directed therapy is also potentially curative. And for those with lesions greater than 5 centimeters, ablation is not recommended. So let's talk about the contemporary types of ablation, specifically Y90 ablation or radiation segmentectomy. So what we're talking about here is delivering an ablative dose of yttrium-90 radioembolic. which, as again, Dr. Giller kind of previewed, this is delivery of beta-emitting microspheres, essentially intraarterial brachytherapy. What it's doing is providing local high-dose tumor irradiation. Millions of spheres are delivered, and that number can be modulated based on the size and area to be targeted. And each is going to treat a 2 to 11 millimeter radial area from the site of deposition. So previously with Y90 therapy, what we would do is get into just the right or left hepatic artery and treat the entire lobe, the entire area with HCC-bearing parenchyma. And you would be limited by the fact that while you are targeting the tumor, yes, you're going to get a lot of collateral or background radiation to non-diseased liver, or I should say still diseased with cirrhosis, but not bearing HCC. And so that would limit the actual dose you could deliver to the tumor because you have to modulate based on preserving the background liver function. What we're doing contemporarily in our institution and many others across the country is delivering Y90 therapy now in a much more selective and segmental fashion. If you can specifically catheterize those vessels feeding the tumor and spare much more of the surrounding parenchyma, you can then up the dose to deliver a truly ablative dose to both the tumor as well as a small margin of healthy liver, with the idea being that this can kind of equate to what would be essentially a surgical segmentectomy, but achieved via radiation therapy. There are numerous papers that support this technique, and I'd like to focus on this one published in Hepatology by Michael Vush. This is a retrospective study looking at 102 patients, kind of evenly split between Child-Pugh A and B. Most of the tumors were in the hepatic dome, emphasizing the peripheral nature, and they were solitary with a median size of 2.5 centimeters. And so compared to the old style dosing of a lobar treatment, which would be about 100 gray that you could safely get away with and not really damage the background liver, they were selectively administering up to 242 gray for a median dose. Of those 102 patients, 33 went on to transplant. In all 33 of those explants, you saw greater than 90% pathologic necrosis within those lesions, with a threshold dose of 190 gray being noted to achieve that degree of necrosis. So a quick example of what this would look like. On the upper left panel, you see a hypervascular HCC in the dome. You can see a very specific, super selective catheterization with a very targeted and narrow zone of delivery of the Y90, targeting both the lesion as well as a small margin of surrounding tissue. And then several months afterwards, what you see looks almost like a resection site. You see local scarring, absence of any viable tumor, and what essentially looks like I said, resection achieved via brachytherapy. So some of the most exciting data to come out has kind of evolved our understanding of the dosimetry and the technique for radiation segmentectomy. I'd like to focus on the legacy study today, which was recently published in Hepatology. This was a multi-center single-arm retrospective study looking at unresectable HCCs less than 8 centimeters. A pretty well-matched cohort of Child-Pugh A, BCLC-A, and C lesions, or patients with pretty good performance status, median age of 66 years. Exclusion criteria included no prior treatment and no extrahepatic disease. And really the key for this was that the median dose delivered in a segmental fashion was now 410 gray in the study. So their primary endpoints were objective response rate by localized M-RECIST criteria, as well as duration of response for the same. So coming to the results, if you look at the overall objective response rate, for best response, you're looking at 88.3%, which is an excellent, excellent number. And if you look at best response stratification, for those with complete response out of this cohort, 84%, 136 patients, 7 with partial response, or only 4%, and 0 with stable or progressive disease by localized M-RECIST criteria. If we go on to look at the secondary additional primary outcome, which was duration of response, you're looking at a median of 15.1 months and a duration greater than 6 months, and over 3/4 of these patients at 76.1%. Kind of showing the data a little bit differently, you can see this waterfall plot. This vast wall of green is showing you all of the patients with complete response. The purples are the handful with partial response, and what you don't see is any patients in the red or the pink, the yellow or the pink, with either stable disease or progressive disease. The small circles are indicating that subset that went on to transplant or resection. So if you look at the overall survival, which actually wasn't the primary outcome of this study, you still have very impressive numbers. A 93% overall survival rate in those patients who did go on to transplant or resection following Y90 radioembolization at 3 years. That's depicted by the dark blue line here in the top of the graph. And even in those patients who didn't go on to transplant or surgery, you still see a very respectable 70% overall survival rate at 54 months post-therapy. So an additional interesting paper that kind of did a subset analysis of the legacy cohort was looking at the correlation of absorbed dose to pathologic necrosis within this group. And so the first chart here is depicting those patients with an absorbed dose of greater than 190 gray showed a much higher rate of complete versus incomplete necrosis. And if you look even further and separate into those who received greater than 400 gray, you had 100% complete necrosis response in lesions treated with greater than a 400 gray to their specific targets. So what do we take from this? The bottom line is that dosimetry matters. High dose is necessary to achieve ablative or curative responses with these lesions. This is the other most exciting trial to be published in 2021 that came out in the Lancet Gastroenterology and Hepatology. And this was the Dosasphere trial. It was a randomized, multi-center, open-label phase 2 trial comparing personalized versus standardized dosimetry, personalized being greater than 200 gray and standardized being the old style 100 gray glow bar treatment. So let's take a look again. This is a 4-center randomized controlled phase 2 trial, well-matched patient cohort, and randomized 1-to-1 to the standard dosimetry arm, which is a goal of 120 gray, versus the personalized dosimetry arm, which is targeting greater than 200 gray to the lesion with limited background dose. And so looking at the primary endpoint for this study, which was index lesion response rate at 3 months using EASL in the modified intent to treat group, you can see almost a 2-to-1 improvement in complete and partial response in the blue bar, which is the personalized or higher dosimetry versus the standardized or kind of lower old school dosimetry. And so very good results here and carried out to objective response rate as well, 71.4%, pretty much on par with the legacy cohort. And although this was, again, not the primary objective of the study, overall survival separated early and stayed separated. This is the kind of curve you want to see for overall survival for a therapy. And so showing personalized dosimetry median overall survival of 26.6 months versus standard dosimetry at only 10.7 months. So with this legacy and Dosasphere data, where did this impact the NCCN guidelines? Well, we now have a new addition to our line here with specifically with radioembolization, delivery of greater than 205 gray to the tumor can be seen with an associated increased overall survival. So moving on to adjuvant therapy to transplant. For those patients who, again, are not potentially resectable but could be transplant candidates, bridge therapy may be indicated to kind of keep them on the list. And so let's talk about this a little bit more in detail. The goal of transplant is to, of course, remove all of those intrahepatic tumor foci and remove the background oncogenic liver, which is cirrhotic. Survival is similar to liver transplant for non-cancer indications, but the problem, as Dr. Geller described, is the scarcity of donors and the fact that patients progress off of the list based on the Milan criteria. And so local regional therapies play a role to decrease tumor size, not only to get them onto the transplant criteria, but they also allow them to receive MELD exception points. So what is the evidence for downstaging? This is a meta-analysis published in Hepatology that showed improvement in 1 and 5-year overall survival rates post-transplant versus transplant alone when downstaging was added. Another systematic review showed about a 48% success rate of downstaging and getting patients to that magical transplant eligibility. And then finally, by Mazzaferro, the original creator of the Milan criteria, this is a phase 2b/3 trial published in Lancet last year that showed overall survival in those with downstaging by any modality compared to transplant alone was improvement in 5-year overall survival of 78 versus 31%. So downstaging works is the bottom line. This is a study looking at liver transplant following Y90 radioembolization as a downstaging modality, retrospective single center study, but they looked at 270 patients following liver transplant who had undergone Y90 prior to that. Of that group, most of them were bridged, some of them were downstaged, and overall survival rates looking at 3, 5, and 10 years of 84, 77, and 60%. Very good numbers. Those patients who had extensive or complete necrosis did have better recurrence-free survival. And the bottom line from this paper was that Y90 is an effective therapy for both bridging and downstaging. And so let's talk about intraarterial therapy as an adjunct to resection. So a new concept that I'd like to speak about is radiation lobectomy, which is a novel neoadjuvant technique to facilitate resection. So as Dr. Geller eloquently described, liver resection is the best option if you're a candidate. Your 5-year survival is excellent. However, a lot of folks are limited by their future liver remnant. And so this is where Y90 can come in. You can do a lobar infusion, which is not only going to treat the entire affected lobe, but it's going to allow for contralateral FLR hypertrophy while controlling the tumor during the time to resection. This is in contrast to portal vein embolization, which is kind of the older technique described, which unfortunately can result in a lot of progression of disease by the time you get to that hypertrophy of the contralateral lobe. So by treating the disease and allowing hypertrophy at the same time, you have a greater cohort of patients who ultimately become eligible for resection. So here's the kind of a visual example of what I mean. This is a focal lesion with a very small FLR if you were to do a right lobectomy of only 34%. Treated with radiation lobectomy, you now have a 4-month follow-up, a treated lesion, and an FLR that's increased up to 69% of what it was previously. So what are the surgical advantages of radiation lobectomy? Well, you have a tumor shift from major vessels, which optimizes your RZO or margin-free resectability. You also have tumor control prior to mobilization or manipulation of the liver. As Dr. Geller again showed, you saw how friable and soft those tumors are. If that tumor is destroyed before you resect it, the odds of spilling lesion in small cells is much better. The induction of FLR hypertrophy also limits the risk of post-op tumor progression by that rapid post-op liver regenerative activity that can happen when you do a large hepatectomy. Here's a specific example from our institution, a patient with multifocal disease, a very small left lobe remnant, treated by my colleague, Dr. Dunn, with intraarterial radiation lobectomy, high dose to the right hepatic lobe. You can see the deposition on the nuclear medicine scan following Y90 administration. And then you can see the hypertrophy of the lateral segment within 3 months, as well as treatment of these lesions, which no longer enhance. And kind of critically for the surgeons, the feedback we got was that when they went in, this is their intraoperative laparoscopic image for this patient, you can see a very clear margin, healthy liver FLR, and very clear demarcation between the treated radiation lobe, which makes resection, I don't want to say a breeze, but a lot easier when you can see that kind of margin. So what about the safety of hepatectomy after radioembolization? This is a very small cohort study of only 12 patients, but they showed no post-hepatectomy liver failures. Again, an area of further study, but preliminary data suggests that this is safe and effective. So let's talk about those folks who are in the intermediate stages where we're looking at chemoembolization and radioembolization for treatment. These are older data, but this is kind of the seminal papers that established the role of transarterial chemoembolization in unresectable hepatocellular carcinoma. Well, ultimately, what do I tell my patients derived from these trials is that you get basically a 2 times increased rate of survival at 1 year, looking at roughly 60 versus 30% based on these numbers for those who undergo TACE versus best supportive care. So what are the contraindications to TACE? A poor performance status, ECOG greater than 2, large tumor burden greater than half of the liver, main portal vein thrombus, and the presence of extrahepatic metastasis. What about Y90 for intermediate stage HCC? We're talking about whole liver or lobar infusions for multifocal disease in the BCLC algorithm. This is a study looking at comparing chemoembolization versus radioembolization, looking at time to progression, favoring radioembolization, 13.3 months versus 8.4, with a higher quality of life. Another study comparing chemoembolization with radioembolization. This was a prospective randomized controlled trial looking at unresectable HCC not ablation candidates, with the primary endpoint being time to progression. And what they showed is very significant numbers. Look at this chart. You can see the early and progressive separation in the Y90 versus the TACE cohort. Time to progression of greater than 26 months in Y90 versus 6.8 months in conventional TACE. So what are the contraindications for Y90? Well, again, poor performance status, ECOG greater than 2, or if you're doing a lobar treatment, bilirubin greater than 2. This used to be very dogmatic, but with the advent of segmentectomy, you can even get away in doing this with patients with very high bilirubins, given that you only are going to treat a very small volume of liver. Toxicities of Y90 include fatigue, lasts about 10 to 12 days, which can be mitigated with steroids in those who can take them. Some mild abdominal pain and discomfort, much better than the post-embolization syndrome from TACE, which can be significant. Fevers and night sweats. And then one thing that always comes up is concern about radiation-induced liver disease. Really is only about 3%, but it only pertains to those who are getting bilobar treatment, which is kind of no longer performed clinically. So how do I decide TACE versus Y90? For single focal tumors or either multifocal tumor confined to one lobe, Y90 offers clear advantages with respect to time to progression, bridging, downstaging, as well as potentially curative treatments in the session of radiation segmentectomy. For those with multifocal bilobar disease, in order to avoid that radiation-induced liver disease potential, TACE may be a better option for these individuals. For those with vascular invasion, either branch or even main portal vein invasion, Y90 can penetrate and treat those lesions much better than TACE. And for those who have lobar disease but high bilirubin, TACE can be done in that setting, whereas Y90 still has that bilirubin cutoff for lobar treatments. We see the advantage for downstaging, Now, Y90 does have a few more steps involved, and patients may have to do up to 2 visits, although that can be actually done in one therapy. But for those with poor compliance or a large central tumor, TACE may be preferable. But for those peripheral tumors and those with potentially even a kind of a marginal performance status, Y90 is going to be superior. So this is kind of the summary where we stand with respect to our local regional therapies. Really, at every stage of disease, we have options. And so I'd like to talk a little bit about combination therapy, specifically how this compares with SBRT, which future speaker Dr. Renz is going to be speaking about. And this is again from the NCCN guidelines in 2021. There's growing evidence of the usefulness of SBRT, or external beam therapy, in management of patients with HCC. And it can be considered an alternative to ablation or embolization when these therapies have failed or are contraindicated. Now, while that sounds a little bit kind of sour on SBRT, I do want to mention that these therapies are complementary. Both tumor location, number, and vascularity plays a key role in choosing which therapy is going to be appropriate. I think SBRT is excellent in treating very small lesions completely non-invasively. Although we pride ourselves in IR and being only minimally invasive, SBRT, there's nothing going in the patient, period. For intraarterial therapies, however, if you have a larger or more numerous lesions, I do think that they have a distinct advantage. And then multiple other factors such as single versus multi-day therapy and patient preferences are going to factor into the decision-making. For lesions greater than 4 centimeters, SBRT and TACE are very synergistic with good results, which I think Dr. Renz is going to speak about. But the bottom line is there's no comparative data yet as the literature evolves. And all we can do is say that multidisciplinary discussion is ultimately the key. And having a good working relationship between your IR and radiation oncology colleagues is going to be very important for those BCLC intermediate stage patients at your tumor board. So talking about a combination with systemic therapy, there's a few papers to mention. This was a large meta-analysis looking at combining chemoembolization with sorafenib and unresectable HCC. Again, looking at very large numbers, multiple studies were included within this. And really what it comes down to, kind of their conclusion was that combination therapy improves overall survival with a combined hazard ratio of 0.74. This is another study, very small cohort, but looking at the safety and efficacy of local regional treatment during immunotherapy with nivolumab. So it did show safety within this, and that was really all they looked at. And what I would want to encourage our audience to look at is multiple randomized controlled trials, which are out there right now, comparing all these combinations. And so when we think about the BCLC, it may seem rather rigid with all these various treatment arms, but the truth is there's a lot of lateral crossover and kind of multimodal network mapping within this algorithm. And a few key studies to point out that are looking at combining therapies, including TACE plus durvalumab and bevacizumab in the intermediate group, TACE and nivolumab, and then Y90 and sorafenib in the advanced group. And so it's an exciting area. We're excited to see where things progress. And with that, I will wrap up and take any questions if there are any. Thank you very much.
Great, fantastic. Thank you, Dr. Klabuka. That was a really comprehensive overview of all the liver-directed therapies. And I think that, multidisciplinary discussion of these cases is so important, and because there are so many options for the patients, but when we discuss them, we come up with, the best option for them to maintain their quality of life and improve overall outcomes. I don't think we have any questions in our chat box. Again, it looks like people are a little quiet today. Do you have any questions, Dr. Monga?
No, my question was rather basic. I mean, it seems like that all these therapies are based off of, the performance status and other types of considerations that you have to take into account. A simple question was really about what was the reason of the hypertrophy in the contralateral lobe? Is it just because you're actually damaging the lobe of the liver where either Y90 or TACE is being introduced, and it's the loss of hepatocellular mass, which is then compensated by the other lobe?
Yeah, that's kind of hitting on the nail there. Specifically, the idea is that for those with, a cirrhotic patient, you need at least a 30% FLR to hypertrophy. Mm-hmm. And so with Y90, the dosing is different for a lobectomy in that you're achieving not only a tumoricidal dose for a lobectomy, where you're targeting a dosage of around 200 gray, which is going to be cytotoxic to the native hepatocytes, which are non-tumor bearing as well. And so that hepatotoxicity to those hepatocytes based on the high dose, as well as the fact that you're going to modulate this to deliver millions of spheres, 15, 20 million spheres as opposed to 40 for a small targeted lesion, you're really blanketing that entire area in a very lethal dose of radiation to the hepatocytes, which then induces FLR hypertrophy on the contralateral side. So when you saw that laparoscopic image, that whole lobe was essentially non-viable. And so that's the idea, is to kind of facilitate these people to control the lesions while allowing that growth at the same time.
You always worry that there may be a theoretical risk of some cells that may metastasize to the other lobe, especially because of the regenerative signals that, because we study basic liver regeneration process and the growth factors and cytokines that are essential for promoting liver growth are some of the same factors that are also positively regulating the tumor cell development and proliferation. Has there been any studies where there is appearance of any metastatic lesion in that other lobe, based on your therapy?
Yeah, so it's a great question. What I would respond with is that the technique is so new, there probably have been about 200 cases done in the United States as to date. So I don't know that it's been studied yet, other than just simply with anecdote. What I can mention is that compared to prior techniques of inducing contralateral hypertrophy, which would be portal vein embolization, what can happen is, while metastatic disease is a concern, yes, but with portal vein embolization, that same trophic factor that's released when you kind of deprive the portal supply to the right lobe that's tumor bearing can cause the tumor that's not being treated in that right lobe to also grow in hypertrophy. And so by doing a therapy that's going to allow contralateral hypertrophy while also controlling the tumor in the lobe, you do get a potentially better chance that at least that index lesion isn't going to progress outside of resectability.
Right.
And so while nobody can really control from micromets to the other side, at least treating the tumor in the side that you're intending to resect is more helpful than simply encouraging hypertrophy and kind of crossing your fingers and hoping that primary lesion doesn't grow outside of your ability to control with surgery. So more to come. It's a great question. I think as our experience and the numbers grow across the nation, I'm hopeful that a study like that will be done in the future.
That sounds great. Thank you.
There's another question in the chat. Should we be using 200 gray or 400 gray for Y90 to get the best result?
Yeah, so that's a question I think that's being studied, and there are different Y90 products out there. And so for the TheraSphere product, really you should be using 400 gray for a targeted radiation segmentectomy. For the SurSpheres or Surtex product, those are the studies that show the 200 gray for the tumoricidal dose. Thus, there is a differentiation and kind of outside the scope of the discussion to talk about the differences in the products, but the bottom line is at least 200 gray should be considered tumoricidal, specifically in a radiation segmentectomy setting, but it depends on your lesion as well as the product that you're using.
Okay, great. Thank you.
Thanks so much.
Okay.
Well, thank you very much. That was outstanding. I think we are running a little bit ahead of schedule, so why don't we take a 5-minute or 4-minute bio break, and then we meet at 10:29 for the next speaker.
And we will have concurrent sessions next.
That already started. The conference session is ongoing.
Oh, okay. The patient roundtable discussion was ongoing at the same time as Dr. Klabuka.
Yeah.
And so in 5 minutes, we'll start with the next talk. Thank you, Dr. Klabuka.
Thank you.
Thank you.
Welcome back, everyone. I'm Paul Monga, and we are at the Community Liver Alliance's Liver Cancer meeting. And our next speaker is Dr. Dulab Monga. She is an assistant professor of medicine within Division of Human Oncology at Allegheny General Hospital, Allegheny Health Network. She's also the program director of Hem/Onc Fellowship, and her interests are in medical management of GI malignancies, especially with the focus on hepatocellular cancer. She's going to talk to us today about medical management of HCC.
Thank you for the kind introduction. And we've had great speakers this morning, and hopefully I can continue to provide more information about the management of HCC. All right, sorry about that. This is just an image of the new AHN Cancer Institute. We moved into this building last year. It's a fantastic space. And we are very excited to be here, mostly for the patients, where we have state-of-the-art facilities. So HCC is the fourth leading cause of cancer-related death in the world. The number of deaths per year in HCC is similar to the incidence throughout the world, which really highlights the high case fatality rate. Over the past years, several new drugs have been added to the drug armamentarium, and today we'll discuss about all of them. So in general, when we talk about HCC, it is a multidisciplinary team evaluation. Most importantly, you want to evaluate the underlying hepatic function, the hepatitis B virus and hepatitis C virus status. You first want to assess for curative treatment options. That is really critical. Our previous speakers spoke really well about the role of resection, transplantation, radiofrequency ablation, and SBRT will be coming up soon. You want to understand the indication and the institutional expertise of regional therapy. You heard about TACE, radioembolization. And I will talk about the role of molecular targeted therapy, the indications, doses, and the side effects, the role of immunotherapy. You always want to encourage your patients to participate in clinical trials, since unfortunately this is a disease that has a high mortality. So yeah, I think you've seen this image several times through the morning, and it is the most practical way to look at staging of HCC. And today I'll be focusing mostly on the advanced stage C, where patients have portal invasion, extrahepatic spread, but still have some preserved liver function and have maintained their ECOG performance status to 1 to 2. So when we talk about systemic therapy for HCC, we talk about molecular targeted therapy and immunotherapy. And then at the end, I'll talk about some of the ongoing clinical trials. So if you look at the treatment landscape, the approved first-line systemic therapy options are listed below. Sorafenib was one of the first ones that was FDA approved in 2007 for unresectable HCC in the SHARP trial. And there was also an Asia-Pacific trial. Later, lenvatinib was studied in the REFLECT trial, where it was studied in a non-inferiority fashion with sorafenib, and it was approved for first-line treatment of patients with unresectable HCC. And then more recently, exciting data from the IMbrave 150 trial, where atezolizumab, which is an immunotherapy drug, was combined with bevacizumab, which inhibits angiogenesis, and this was approved in the first-line setting. Nivolumab was also studied in the first-line setting, and although we did see some clinical benefit in terms of response rates and some complete responses, in terms of overall survival and progression-free survival, the pre-specified hazard ratio was not met, and it was considered a negative study, and that was CheckMate 459. So let's go to the basics. The phase 3 SHARP study looked at the comparison of sorafenib versus placebo in advanced HCC. And the common theme you will see with all the trials that I present is that most of these patients, in fact, almost all the patients had Child-Pugh A cirrhosis. So we have an unmet need in patients with a higher degree of cirrhosis like Child-Pugh B. Unfortunately, Child-Pugh C, because of their bad underlying liver disease, most of them are really suitable for hospice or palliative care. And so in this study, the primary endpoint was overall survival and time to symptomatic progression. And the dose was 400 milligrams twice a day. And before I show you the results, I just want to talk briefly about how sorafenib works. So on the left, you can see the tumor cell, and on the right, you can see an endothelial cell, which could be either a vascular or lymphatic cell. And in the pathways that are responsible for survival and proliferation of these tumor cells, there's several growth factors that are imperative for tumor growth. So sorafenib works on the RAS, RAF, and MEK and ERK pathway, and it inhibits survival and proliferation. And typically, these tumor cells have growth factors that bind to the receptors on the endothelial cells. And you can see in the image on the right, you can see these growth factors binding to the extracellular receptor, and then they affect downstream signaling that affects angiogenesis, differentiation, proliferation, migration, and tubule formation. So in this study, you can see here, this was the overall survival. It was 10.7 months versus 7.9 months in the placebo. And this was highly statistically significant. And it was the first study to show overall survival improvement over placebo. You can see in the time to progression, again, a benefit 5.5 months versus 2.8 months. And this was also statistically significant. The important things to remember with sorafenib when you're taking care of these patients, the most common side effects that we see are diarrhea, hand-foot syndrome, and anorexia. Lower risks are bleeding and liver dysfunction. So a lot of education for the patients. We at AHN Cancer Institute have oral chemotherapy nurses who do a fantastic job calling the patients and making sure that they're following the instructions with moisturization of hands and feet and keeping up with their diarrhea management. So as you can see, the treatment for HCC from 2007 to 2017 was just sorafenib. And then we started looking at other tyrosine kinase inhibitors. And one of them is lenvatinib. And this is an oral multi-kinase inhibitor. It targets VEGFR 1, 2, and 3. It also targets FGFR 1, 2, and 3, and 4. And in addition, it targets RET, KIT, and PDGFR alpha. So this was studied in a non-inferiority study. It was a phase 3 trial of lenvatinib versus sorafenib in patients with unresectable HCC. These patients were all Child-Pugh A, BCLC stage B or C. They all had adequate organ function. And the patients who were excluded were those who had more than 50% liver occupation, clear bile duct invasion, or portal vein invasion at the main portal vein. So they did not have very, very advanced tumors. Just remember that, because when we talk about the I Am Brave study, that's where the difference was. ECOG performance status was 0 or 1. So these are a particularly good group of people. And they were randomized to either lenvatinib or sorafenib, and the primary endpoint was overall survival. And here you can see in the Kaplan-Meier plot here that the overall survival was 13.6 versus 12.3, and this was considered non-inferior to sorafenib. And you can see the overlap of the curves. In terms of progression-free survival, for lenvatinib, it was 7.4, and for sorafenib, 3.7, and that was statistically significant in favor of lenvatinib. But remember, that was not the primary endpoint. And if you look at the objective response rates, higher with lenvatinib at 24% versus 9% with sorafenib. Now, if you look at the historical sorafenib study, the response rates were only 2%. Here we see a 9% response rate. Why is that? Of course, this is a different study. Secondly, maybe the physicians know how to handle the sorafenib toxicities better, and patients are staying on sorafenib longer. But here you can see that, again, in the waterfall plots, there were some complete responses with lenvatinib, about 6 patients, and with sorafenib, about 2 patients. So at the end of the day, this was a non-inferiority study for lenvatinib versus sorafenib. However, lenvatinib had better objective response rates and a better progression-free survival. Some of the things to remember with lenvatinib versus sorafenib side effects: lenvatinib tends to give you more hypertension, and whereas sorafenib can cause more hand-foot syndrome. So depending on your patient population, if you have someone with uncontrolled hypertension, you probably would want to go with the sorafenib pill. And if you want to avoid hand-foot syndrome, you could use the lenvatinib in your patients. Other side effects that I commonly see are diarrhea, and dysphonia is a common one where patients can develop hoarseness of the voice. Unfortunately, there's no treatment for that. So just give them a lot of TLC and try to get them through treatment. Hypothyroidism is something that people forget about. So we always check a baseline TSH and continue to follow it along the way every 8 weeks. So next we'll talk about nivolumab. This is an immunotherapy drug, a PD-1 inhibitor. And so our previous speakers had spoken a little bit about immunotherapy, but typically what nivolumab does is it blocks the interaction of PD-L1 that is expressed on tumor cells with the PD-1 that's expressed on T cells, and it inhibits all the signaling processes that cause immune suppression in the tumor environment. And therefore, it increases the number of T cells that then go ahead and attack the tumor cells. So nivolumab was first tested in this study called the Checkmate 040 in patients with advanced HCC. This was a phase 1, phase 2 dose escalation study, and they included uninfected patients. They included patients with HCV, patients with HPV, and also patients who are sorafenib progressors and sorafenib naive patients. And they went from a dose escalation study to the dose that we use now, 3 milligrams per kilogram in the expansion phase. So here you can see the change in the target lesions from baseline in all the different subtypes: uninfected patients, HCV patients, and the hepatitis B virus patients. And the ones with the asterisks are the ones who had a partial response. And you can see we also had 3 complete responses in this phase 1, phase 2 study. If you look at the objective response rates, about 15% with 3 complete responses. This was in the dose escalation cohort. We also did not see any correlation between PD-L1 expression and response. And in the expansion cohort, again, responses occurred regardless of the PD-L1 status, and the response rates of about 16% with 2 patients who had a complete response. So, we always ask the question, what about my Child-Pugh B cirrhosis, B7? What do I do with that patient? And, there's very little data, but this is a study, a very small study in patients with advanced HCC, Child-Pugh B naive or experienced. There are about 49 patients here who were exposed to nivolumab, 240 milligram every 2 weeks, and until progression of disease or unacceptable toxicity. And here you can see that they included BCLC stage B, C, and D. Most of them were C. Child-Pugh classification B7 was in 76%, and 22% had B8, and half of them had received sorafenib prior. And here you can see, again, it's a small study. In blue, you can see the sorafenib naive patients, and in red, you can see the sorafenib treated patients, and the bars below the line are the responses, and the bars above the line are the ones who progressed. And then on the right, you can see how the tumor burden changed per investigator assessment. And this is a spider plot that shows in green the patients with stable disease, in purple the patients who had a partial response, and then you can see in blue are the ones who progressed. So you can see that we still saw some responses, but the question always remains, how did they do with this treatment with their bad underlying liver disease? So the treatment-related adverse events were manageable. The rates of discontinuation due to adverse events were not higher than the Child-Pugh A cohort. The hepatic adverse events were not higher in the Child-Pugh B cohort versus the Child-Pugh A cohort. The objective response rates were about 10%. Median overall survival, if you look at all the patients, naive or treated patients, 7.6 months. For the sorafenib naive patients, it was 9.8 months. And for the previously treated patients, it was 7.4 months. So I think in carefully selected patients with a good performance status, you could consider using nivolumab. Now, Checkmate 459 was a study that compared nivolumab versus sorafenib as a first-line treatment in advanced HCC. This was a randomized open-label phase 3 trial. And again, patients had Child-Pugh A disease with a good ECOG performance status, and their primary endpoint was time to progression and overall survival. And here they received nivolumab versus the standard dose of sorafenib, and they were all treated until progression of disease or unacceptable toxicity. So here you can see the graphs for overall survival and progression-free survival. You can see a slow widening of the curves here. The median overall survival was 16.4 months versus 14.7 months. The progression-free survival was 3.7 months versus 3.8 months. And unfortunately, the predefined threshold of statistical significance for overall survival with nivolumab was not met, although nivolumab did demonstrate clinical benefit in terms of objective response rates. For nivolumab, 15% versus sorafenib, 7%. So this was a bit of a disappointment. Although we do see some response rates, the endpoints of overall survival and progression-free survival were not met. Next, I'm going on to the IM-BRAVE 150 study. This was a study utilizing atezolizumab with bevacizumab versus sorafenib for first-line treatment of HCC. So atezolizumab is a PD-L1 monoclonal antibody that works similarly to nivolumab, and I had shown you the mechanism there. And so you have to be very cognizant of the potential adverse events with immunotherapy. When you say immunotherapy, what happens is you have all these T cells running around in your body and attacking your organs, and not only the tumor cells, but it can attack your other organs. So you could develop colitis. You can get all the itises that patients can develop with an autoimmune disease. So dermatitis, colitis, thyroiditis, you could get hypopituitarism. So these patients need to be monitored very carefully and on a regular basis. And bevacizumab is a drug that's been around for a long time, has been used in treating several other cancers like colon cancer. And so the way it works is it's a monoclonal antibody to VEGF-A, which is vascular endothelial growth factor, and it inhibits angiogenesis. So some of the potential side effects to remember are hypertension, risk of wound healing problems. So you have to wait at least 4 weeks after surgery to initiate bevacizumab. There are also risks with the bowel perforation. And in this situation where you have HCC and patients have varices, you have to worry about variceal bleeding. And in this study, patients were required to have an EGD, an assessment of varices and treatment of varices if needed before going on this clinical trial. So having said that, the initial trial that was looking at atezo and bev was the GEO-30141 trial, which was a randomized phase 1b study that did show a potential benefit in patients with advanced HCC. And the objective response rates in that phase 1b trial was about 36%, which was the highest that we've ever seen. And that is why we embarked on this phase 3 trial. These patients had locally advanced or metastatic and or unresectable HCC, and with no previous systemic therapy, Child-Pugh A, and a good performance status. So in this study, the co-primary endpoints were overall survival and progression-free survival. And this trial included subgroups of high-risk patients, which, if you recall, I said in the lenvatinib study, they did not have high-risk patients. So 40% had macrovascular invasion and specifically included patients with 50% hepatic involvement or main portal vein invasion or invasion of the portal vein branch contralateral to the primary involved lobe. So atezolizumab and bevacizumab were compared with sorafenib and treated until progression of disease or intolerable toxicity. So here you can see the overall survival on the left. At 6 months, 85% were alive in the Tezo-Bev arm versus 72%. And it was not evaluable at the time of the presentation. Sorafenib, the overall survival was 13.2 months with a hazard ratio of 0.58, which was highly statistically significant. The progression-free survival between Tezo-Bev and Sorafenib was 6.8 versus 4.3 months with a hazard ratio of 0.59 and statistically significant. And if you look at the objective response rates, 33% versus 13.3%, which is not too far from what we saw in the phase 1b study. Complete response rates of 10% versus 1.9%. These are updated from ESMO. And the median follow-up was 8.6 months. So very excited to see these results for our patients. If you look at the quality of life that was patient reported, again, you can see the median time to deterioration of disease and quality of life. With the Atezolizumab and Bevacizumab, it was 11.2 months versus 3.6 months in the Sorafenib arm. So another plus for our patients, maintenance of quality of life. If you look at the safety, on the left are the Atezo-Bev bars, and on the right are Sorafenib, and you can really see just by looking at this that the patients on the Tezo-Bev arm had fewer all-grade adverse events and grade 3 to 4 adverse events, except for hypertension, which is easily manageable. The other important things to remember, like I said before, EGD within 6 months of initiating treatment was required to evaluate for varices, and varices of any size according to local standards of care had to be treated. Upper GI bleeding rates in Atezo plus Bev versus Sorafenib groups was 7% versus 4.5%. And this was consistent with historical data that we see with Bevacizumab. Another study was was interesting is the Durvalumab and the Tremelimumab in unresectable HCC. It's a mouthful of words, but these are also immunotherapy drugs targeting PD-L1 and CTLA-4. This was a randomized phase 1/2 trial in which patients with unresectable HCC with progression or intolerance to Sorafenib with or without hepatitis B or C were treated for 4 doses and then with Durvalumab monotherapy. And here you can see in the waterfall plot, you see some good responses in the uninfected and also in the hepatitis B and C virus patients with confirmed objective response rates up to 25% in this population. So the phase 3 trial is the Himalaya study. That is a multi-center randomized open label phase 3 trial, also looking at these combinations versus Sorafenib, and the primary endpoint is overall survival. The final results of this study have to be still presented, but the initial results seem to show that the combination has a favorable safety profile, and it met its primary endpoint of overall survival versus Sorafenib. And also Durvalumab monotherapy met the overall survival endpoint of non-inferiority versus Sorafenib. And so the final results are expected soon at an upcoming meeting. In terms of second-line options, we have several here. And you can see, again, all of them are in Child-Pugh A category. And Cabozantinib in the Celestial trial, Nivolumab, we already talked about. Pembrolizumab was looked at 2 different trials. Ramucirumab was looked at specifically in all patients and then eventually approved in patients with AFPs of more than 400. You have Regorafenib, and then the IPI and Nivo combination was also looked at an arm in the Checkmate 040. So quickly going through this, Keynote 240 compared Pembro to placebo, and it was Child-Pugh A. And this was in previously treated. So we're talking about second line now. Co-primary endpoints were PFS and overall survival. Unfortunately, we did not meet the pre-specified level of statistical significance for OS and PFS. However, objective response rates were higher with Pembro versus placebo, 18% versus 4.4%. And this was statistically significant. And the median duration of response was also very long, 13.8 months. This is the Ipi-Nivo combination. And here they used 3 different types of dosing. And you can see that arm A, 22.8 months overall survival. And that was a combination of Nivo 1 and Ipi-3 dosing. So that was very exciting. But remember, Checkmate 040 was a phase 1, phase 2 study, and the phase 3 trial is ongoing. Ramucirumab binds to VEGFR2, and this was studied in the REACH study originally. They saw that there was a signal in patients who had an AFP of more than 400. So they compared ramucirumab versus placebo, and the primary endpoint was overall survival. And here, a modest improvement in median overall survival of 8.5 versus 7.3 months. Not very exciting, but still, this is an option for patients. Progression-free survival, 2.8 versus 1.6, and this was statistically significant. So that is approved for patients with an AFP of more than 400. Regorafenib is another TKI that targets multiple protein kinases and VEGFR1, PDGFR alpha, FGFR1 and 2. And this was studied in the RESOURCE study and in Child-Pugh A liver disease. So it was Rego versus placebo. Primary endpoint was overall survival. And the median overall survival was 10.6 versus 7.8 months. And the progression-free survival was 3.2 versus 1.5 months. So this was the first agent proven to be of survival benefit after failure of sorafenib. With TKIs, we talked about the various side effects of hypertension, bleeding, changes in liver function tests. Cabozantinib versus placebo was studied in the Celestial trial, again, another phase 3 trial. This targets VEGF receptors, MET and AXL. And again, Child-Pugh patients, Cabo was compared to placebo in the second-line setting. And here you can see, again, median overall survival 10.2 versus 8 in placebo. That was statistically significant and also an improvement in progression-free survival. So another option for our patients. So coming to the important slide of sequencing, how do we sequence all these drugs? So you have atezo-bev, which is now considered the first-line therapy for our patients, unless there's a true contraindication, such as with atezo. You need to be careful. If a patient is a transplant patient, you cannot give atezo. If they have an autoimmune disease that is uncontrolled, you cannot give atezo. There are select cases of patients who have autoimmune diseases that are well controlled. You can consult with a rheumatologist and you could challenge them with atezo, but again, it's a case-by-case basis. Lenvatinib and sorafenib are considered also first-line therapies that you can give to your patients. And if you progress on atezo and bev, what do you do next? Do we have any studies that have looked at second-line lenvatinib or sorafenib? And I'll talk about a retrospective study that was just published recently that does show some benefit of using lenvatinib or sorafenib second-line and also with manageable side effects. Now, what about second-line therapy after you progress on sorafenib? We talked about all the drugs, Rego, Ramu, and Cabo. What is apatinib? This was studied in a Chinese population and was looked in the second-line setting for Child-Pugh class A or B less than 7. It's not available to the US population. Pembro, we talked about the studies with Pembro only for Child-Pugh class A second-line, Nivo again, class A or B7, and then Ipi-Nivo for class A only. Donafenib was recently published. It was a study, again, exclusively Chinese population versus sorafenib in first line. And it is a sister drug of sorafenib, except that it has a better pharmacokinetics. And the difference in survival was 12 months versus 10 months. So I think that in the Chinese population, donafenib may become the first line therapy we will see in the future. This is the retrospective study that looked at progression after first-line atezo-bev. This was a multi-center retrospective study in patients from Korea, Hong Kong, and I think Singapore. 71 patients were treated with atezo-bev, 49 received subsequent therapy. Of them, 29 received sorafenib, 19 lenvatinib, and 1 received Cabo. And they were all Child-Pugh A. Objective response rates were 6.3%, disease control rate of 63%, and overall survival of 14.7 months, which is quite impressive. If you look at the separate lenvatinib and sorafenib data, it looks like lenvatinib is more favored compared to sorafenib. And in terms of adverse events, any grade adverse events were seen in 85%, grade 3 in only 16%. And the common things we see are hand-foot syndrome, fatigue, hypertension, diarrhea, and these are easily manageable. So the conclusion of that study was that second-line treatment with TKIs showed comparable efficacy and manageable toxicity. So this is just the phase 3 trials that we talked about. So in general, you can see in the second line setting, we get an average median overall survival of 8.7 to 10.7 months. And then the key phase 3 trials with immunotherapy for first line treatment of advanced HCC are listed below. And you can see there are various combinations of TKIs with immunotherapy. And so we're looking forward to the results of these trials so that we can help our patients. Some of them have response rates higher than 35%. So lots of hope in the future for our patients. And then the last slide is, my husband has been nudging me for a while now. So the last slide is adjuvant therapy and combination therapy with local regional therapy. So we're really looking forward to the results of these trials where we're combining TKIs with immunotherapy or immunotherapy combinations with TACE or compared to TACE alone or compared to local ablation. And I think doing all these trials is going to increase the number of options that patients will have in the future. And I think this is my last slide. Research is to see what everybody else has seen and to think what nobody else has thought. So thank you very much for your patience. And I'm happy to take any questions.
Great. Thank you, Dulab. That was comprehensive and wonderful. We have no questions still from the audience. And for the sake of time, I think we're going to move on, but I have one question. There were some complete responses that were noted in lenvatinib and even atezo-bev combination. Have people done any subset analysis to identify any biomarkers that could be useful in trying to stratify patients for those therapies?
Yes, that is a great question. And yes, there are multiple studies that are ongoing trying to look at various biomarkers. And unfortunately, in a clinically proven fashion, the only biomarker that has shown some response indication is the alpha-fetoprotein of more than 400, which is a blood test. So at the molecular level, nothing that is proven, but there are ongoing studies. And I hope that next time when we present here, we'll have more information on that.
Well, thank you very much. And I think you want to introduce the next speaker.
So our next speaker is Dr. Paul Renz. Dr. Paul Renz is a wonderful colleague of mine. I work with him on a daily basis at Allegheny Health Network. He is a radiation oncologist at AGH, specializing in gastrointestinal tumors, stereotactic treatment, and more recently, the MR linear accelerator. He went to the School of Pitt for undergraduate and graduate studies and completed his medical school training at Lake Erie College of Osteopathic Medicine. And at the current time, he is a faculty member who is treating our HCC patients with passion. Dr. Renz, take it away.
All right, I'm having some technical issues with the webcam, so we're probably just going to go full screen and try this. Hello, thanks for having me today. My name is Paul Renz. I'm one of the radiation oncologists at Allegheny General Hospital, specializing in GI malignancies, and today I'll give you a brief presentation on ablative radiotherapy for liver malignancies, specifically focusing on hepatocellular carcinoma and its management. So I have no disclosures. Before I get started today, I'd like to go through a brief disclaimer. I'm going to be discussing numerous liver-directed therapies today, and I don't want to contend that any one therapy is better or worse than the others. I simply want to portray that the treatment of hepatocellular carcinoma is a multidisciplinary team-based approach with many specialties involved in a very collaborative-based care. We have our interventional radiology colleagues giving therapies like Y90 TACE and RFA, our surgical oncology colleagues being the backbone of treatment with transplant and hepatic resections. We have our medical oncology colleagues giving systemic therapy and managing the patients, as well as our GI and hepatology colleagues being very vital to optimizing liver function and performing needed endoscopic intervention. As a radiation oncologist, I feel we fill a very niche role within hepatocellular carcinoma, but can be a big part of the team if given the opportunity. And so like I said at the beginning, we will focus our topic discussion on liver-directed therapies with a focus on radiation oncology with hepatocellular carcinoma, but it can be used for other pathologies under the guise of liver-directed treatments, including cholangiocarcinoma and other metastatic disease. But we'll focus today specifically on hepatocellular carcinoma. So what I show here is an older depiction of the hepatocellular carcinoma treatment paradigm. This stratifies hepatocellular carcinoma based on their BCLC stage category, which is, a combination of the size and underlying degree of cirrhosis as well as performance status. And in the patients with small singular tumors with good liver function and performance status, they're candidates for partial hepatectomy, as they have worsening cirrhosis or underlying cirrhosis or more multifocal tumors. They become candidates for resection as well as transplantation. And then as things start to evolve into more underlying cirrhosis and more larger or multifocal tumors, we enter the realm of liver-directed therapies. And I show this kind of older depiction to show that in this older depiction, those liver-directed therapies were called palliative treatments, and they consisted of TACE and sorafenib, and quickly morphed into best supportive care. But where does what I show below is a similar depiction of this flow diagram of HCC treatment, but work done by Laura Dawson's group in a review article, which is very pertinent to more modern day treatment. It dictates more role of our liver-directed therapies, including ablative percutaneous ablation, TACE, as well as where radiotherapy fits in, both in the definitive setting as a primary treatment for unresectable in patients not suitable for transplantation or other ablative modalities, also as a bridge to transplantation in patients that require that. In addition, it fits into the multimodality treatment of multifocal and large HCCs, or patients with more underlying comorbidity and cirrhosis, in combination with our colleagues doing TACE, sorafenib, and others. But still, in the world of hepatocellular carcinoma, the gold standard is transplant. As one of my mentors always kind of taught me, a patient has one liver but two problems: the underlying hepatocellular carcinoma and also their underlying cirrhotic changes and cirrhosis. And so transplant remains the gold standard because it solves both of those issues with one kind of procedure. But to obtain a liver transplantation, like we've heard in some of our other kind of talks, that you have to meet certain criteria and have certain disease characteristics that fit within those criteria to be successful in your liver transplant. And those criteria classically are the Milan criteria of 1 lesion less than 5 centimeters and 3 lesions less than 3 centimeters. Now, many patients might meet those Milan criteria for liver transplantation, but regardless, the issue still remains that they have to obtain a donor liver in order to get their transplant. And the way that the United Network of Organ Sharing organizes and administers livers is through UNOS points. Points are given based on the size, shape of the tumor, as well as the underlying MELD score of the patient and time on the transplant list. So when patients have small unifocal tumors and a good functioning liver with a low MELD score, they may stay on the transplant list for the greater part of 6 months or a year before they obtain enough MELD points to then get their liver. Now that can be somewhat nerve-wracking because during that time tumors can grow and become outside of the Milan criteria for transplantation, which opens up the opportunity for treatments with liver-directed therapy such as radiotherapy for bridge to transplant. So like I said, the rationale for bridge to transplant then comes into play while these patients are waiting for their UNOS points. And these extended wait times lead to the risk of becoming ineligible due to disease progression. Therefore, doing liver-directed therapies as a bridge is beneficial to hold the tumors at bay while we wait for eligibility for a donor liver. At the same time, there's also a bridging procedure and a downsizing to meet Milan criteria that is a very viable option for patients who are slightly outside of Milan criteria. Patients who have a single tumor greater than 5 centimeters or multiple with any one greater than 3 can oftentimes be targeted with liver-directed therapies to downsize their tumors and render them now eligible for liver transplantation. And here is just another example of that with UNOS has now accepted criteria which are considered acceptable for transplantation if lesions are successfully treated with bridging procedures and are stable. And people are eligible for MELD exemption points if completing these prior local regional therapies for 1 lesion greater than 5 centimeters but less than 8. For 2 or 3 lesions that meet the following criteria of each lesion less than 5 centimeters with at least 1 lesion greater than 3 centimeters or a total diameter of less than 8. Or 4 to 5 lesions, each less than 3 centimeters with a total diameter of less than 8. So this just opens up a very unique opportunity to bridge patients and downsize them and enable more patients to obtain this kind of life-saving therapy with liver transplantation. But despite our best efforts to downstage patients or obtain livers for transplantation, many patients are still rendered ineligible for transplantation. And in that kind of disease category, the liver-directed therapies come in as the primary or definitive treatment for hepatocellular carcinoma. And in the definitive treatment of hepatocellular carcinoma, a multidisciplinary treatment approach is paramount to optimal outcome. There are multiple different modalities which are tailor-suited to multiple approaches based on the size, shape, and tumor anatomy, as well as patient factors including logistics, travel, and preference. So things like radiofrequency and microwave ablation can be limited by location next to the diaphragm or great vessels, as well as certain sizes. Taste can be limited by high bilirubin, tumor thrombus, or aberrant vasculature. SBRT can be limited by underlying cirrhotic changes, as well as location next to bowel, and among others. This is just kind of an example that, of all these liver-directed therapies, the location and size and these multiple factors play a role in deciding what particular modality would be optimal for that individual patient. It's a very tailored and individualized approach to patient care, and hence the multidisciplinary nature being so paramount. So you might ask yourself, would you just get to the point and where does radiotherapy fit in with the management of hepatocellular carcinoma in the definitive, bridge to transplant, and locally advanced settings? So the question many people ask is that radiotherapy seems like a relatively new development in the treatment of HCC. And that where was it in the early years as a primary treatment modality? Well, hepatocellular carcinoma is a radiosensitive tumor. It does respond well to radiation, and I present some data from Laura Dawson's group in Michigan showing that it's a tumor with a lack of a dose response. And, the holy grail of radiation is we give more radiation, we get more response, and more radiation is better. But the flip side of that argument is once the tumor has been ablated or the tumor is dead, it's dead, and that the increase in radiation dose leads to no extra cell kill and only increase in toxicity. So hepatocellular carcinoma as a tumor itself is very exquisitely sensitive to radiation and relatively low doses. And Laura Dawson's group showed this in a number of different cohorts, showing a very limited dose response to reasonable dose of radiation and quite high escalated doses of radiation. So the case being that hepatocellular carcinoma is very radiosensitive, but it has always been limited by the fact that it is within a very radiosensitive organ, being the liver. The liver has historically been very sensitive to radiation. And it wasn't until the advent of more modern therapies that we were able to treat liver tumors successfully. The way that radiation was done in the 70s and 80s was, without the advent of CT scans, and was done with fluoro and plain film imaging. And a radiation oncologist in the 70s and 80s would have taken a wax pencil and drawn on a plain film X-ray and created his radiation port in a very crude way, which they would have then poured a big lead block, hoisted into the head of a cobalt linear accelerator, and treated with a very limited beam arrangement to a large area of the patient's body. And that was preclusive of treating liver tumors because the liver is too sensitive to treat large portions of it to high doses of radiation. So it was kind of a disconnect that the hepatocellular carcinoma tumor in general was very radiosensitive, but also its surrounding environment being within the liver is also preclusive. So it wasn't until the advent of modern techniques that we were able to do stereotactic treatments and more ablative focus treatments in the ability to treat these tumors. So here's an example of what would be a more old-fashioned radiation technique with a two-beam arrangement delivered through the anterior and posterior angles of the patient. And you can see on the right the dose cloud of radiation with the red and green being the higher dose of radiation, that everything in between those two beams is getting the full dose of radiation. The spinal cord, a large portion of both of the kidneys, a large portion of the liver, as well as some of the stomach. And it's not very targeted, it's very crude, and that limited the ability to give meaningful radiation dose, and it also led to more toxicity. But like I alluded to, we have more advanced radiotherapy techniques, and I'll focus today more exclusively on stereotactic radiation, specifically stereotactic body radiotherapy. It's also known as stereotactic ablative radiotherapy, SBRT or SABR. Those are interchangeable terms. Another term that's often used is stereotactic radiosurgery or radiosurgery. That is also a synonymous term. What that means is that we use stereotactic coordinates to isolate the tumor in 3 planes. We use a multiple beam arrangement or arc therapy to be very conformal with our dose distribution. We use strict motion management and image guidance to have 2 millimeter accuracy. And with all of that, we are able to deliver more ablative doses of radiation. So here I've listed a conventional course of radiation, 50 gray in 25 fractions or 25 treatments at 2 gray per fraction. That gives, through some radiobiologic calculations, a biologic equivalent dose of approximately 60. When we deliver SBRT type doses, below is 50 gray in 5 fractions. That's a conventional SBRT type dose with 10 gray per fraction, and a biologic equivalent dose which is 40% higher at 100. So that 100 BED is kind of our radiation oncology benchmark for an ablative tumor treatment. So we're able to deliver that dose quite easily to the liver with not much issues in toxicity. So in addition, the radiation with SBRT is more outpatient, it's quick, it's convenient, it's cost effective. We deliver this radiation within 1 to 2 weeks as opposed to a conventional old-fashioned course of 5 to 6 weeks. So here's an example of an SBRT treatment. On the top left plane, we have our tumor isolated with gold fiducial markers. We have outline of the tumor volume with margin for setup variability. In the middle plane, we have the multiple beam arrangement targeting that tumor. On the right plane, we have the dose cloud showing the red high dose of radiation with very limited low dose spill. And then below, we have our daily onboard imaging. So we can plan this radiation very accurately, but we also have to be able to line up on a day-by-day treatment aspect. And so what the patient will have is on the treatment table a cone beam CT scan, which is done with 4D motion management, and we're able to kind of isolate that tumor in real time to target and hone in on those gold fiducials to deliver the treatment very accurately. Here is yet another example of an SBRT treatment targeting another liver lesion, much in the same way I previously showed. Here is yet another depiction of an SBRT treatment, only this time using a volumetric modulated arc therapy technique, which enables a continuous arc of radiation treatment being delivered around the patient in real time, which enables even more precision and conformal dose distribution. You can see the dose cloud in the top two right panes, and then as well below their corresponding cone beam CT imaging showing the tumor localization at the time of treatment with gold fiducials being placed. So with all of those different SBRT treatment plannings that I showed, I'd like to show this slide as well, which shows the kind of variability and breadth of different tumor locations that we can treat. Medial, inferior, superior at the dome. There's no one location that's kind of off limits for SBRT, but there are some technical limitations when tumors close to bowel, when patients have erratic breathing, or numerous other kind of technical challenges. But lo and behold, being part of that kind of multidisciplinary treatment approach, we can fill a role in treating some of the harder to reach tumors. So one of the limitations with radiation is the underlying cirrhosis, and the degree of that being challenging to spare functional hepatic parenchyma. So additionally, in addition to advanced targeting and motion management and daily image guidance, we also do functional treatment planning with our cirrhotic patients to map out the functional liver. This is an example of a SPECT CT scan used for that functional treatment planning to highlight the areas of active hepatic function. And when we plan our radiotherapy with this functional treatment planning, we're able to more accurately spare the functional hepatic parenchyma and target our beams in a way that takes advantage of the cirrhotic morphology and the patches of less active liver. And the outcomes for SBRT are pretty good. The local control, like I said, it's a very radiosensitive tumor, is upwards of 80 to 90% at 1 to 3 years, depending on which kind of study you've read, with kind of limited toxicity and very limited progression of Child-Pugh scores. And radiotherapy and SBRT compares fairly well with some of our other liver-directed therapies. Here's some work from the University of Michigan comparing SBRT to percutaneous ablation and TACE, showing very similar, if not slightly better outcomes in comparison. But, lo and behold, I am hesitant to put up a slide like this in a presentation where I've kind of hammered home the complementary treatment modalities as well as the multidisciplinary team approach. Most of the hepatocellular liver-directed therapy data, in my view, is somewhat biased. You know, when you read a radiation therapy authored article, it's oftentimes biased towards SBRT, just as some other competing modalities may be. And so I don't put up this slide to contend that SBRT is better than RFA or TACE, but to say that it is comparable and in the right setting, a very viable option. Now, most of the tumors that I showed us treating earlier were kind of small, discrete 2, 3, 4 centimeter lesions, and oftentimes those are also amenable to things like selective TACE or percutaneous ablation or even hepatic resection. But you know, where does radiation fall in when we get our kind of massive HCCs or our large HCCs? We can still do stereotactic techniques with the same kind of SBRT technique. Same SBRT techniques, aside from that we oftentimes have to fractionate a little bit more. Instead of 5 fractions, we have to protract the fractionation to be somewhat more gentle on the liver and the body, and to 15 or 20 fractions. Oftentimes we will add things like radiosensitizing TACE and do radiotherapy as a boost to that, as well as oral capecitabine. In addition, we use advanced treatment planning techniques with IMRT and VMAT to shield the adjacent organs such as the uninvolved liver, stomach, colon from the tumor, and deliver a very ablative dose to the necrotic core of the tumor. But still, as good as we are getting at treating these liver tumors with radiotherapy, there's still quite a lot of room for innovation. And one of the next levels of innovation for hepatocellular carcinoma and radiotherapy is using MR-guided radiation therapy. And this slide on the right kind of shows a particular kind of evolution of radiation and showing over time our performance and how we have gained the ability to treat tumors more effectively as technology has advanced over the decades. We started, as I alluded to earlier, with very crude radiation techniques with very archaic imaging by today's standards, to advancing our radiation treatment devices with multi-leaflet collimators and SBRT and intensity modulation, as well as 3D CT. And now our next line of performance is to use the extra precision of MRI to better guide our therapy. Not only guiding our therapy with daily imaging being better, but also guiding our therapy with adaptive treatment planning in real time. So one of the true benefits of MRI-guided therapy is that we can get a real-time image at that time and customize the radiation treatment plan on a day-by-day basis to really conform the radiation to the tumor and avoid the organs at risk. So on the left is an example of an MRI LINAC, and below is our MRI LINAC at Allegheny. It's, believe it or not, harder to get in there and take a picture with the magnet than you would think. So this is a screenshot from one of our monitors. So that was the best I could do so far. And here's a reference for further reading on MRI-guided radiation therapy if anyone has some interest in that. These radiotherapy techniques can be used with other histologies, including oligometastasis or cholangiocarcinoma. However, we're going to center our talk on hepatocellular carcinoma, so we won't touch base on those today. But SBRT can also be combined with our other modalities. So I've alluded to this multidisciplinary approach, and oftentimes we'll use multiple modalities in the same patient to achieve our ultimate goal of downstaging for transplant, of bridging to transplant, or definitive treatment. Radiotherapy has been successfully and safely delivered as a combined modality with radioembolization in Y90. And here is a paper from Sinai in New York showing a very good safety profile of doing radiotherapy in Y90 in combination with effective, highly effective local control. SBRT can be combined with transarterial chemoembolization in a quite synchronous way. There is a synchrony between the radiosensitization of the chemotherapy given to the tumors, followed by SBRT boost, which can be quite effective. Just kind of highlighting the team-based approach that I've kind of mentioned so often in this presentation, that interventional radiology and radiation oncology can be kind of a great marriage of treatment approaches in a collaborative way to achieve very good outcomes and very good results with TACE and radiation. As this paper has showed, the combination of TACE plus SBRT as a boost to TACE showed significant improved progression-free and overall survivals when you compare that to standard of care sorafenib alone. So, the treatment can be quite effective and very limited toxicity. But I'd be remiss to mention SBRT and hepatocellular carcinoma without alluding to the era of immunotherapy as well. And as we've seen immunotherapy having more effect in hepatocellular carcinoma, the question then remains with this synchrony of immune therapy and SBRT and how that marriage can come together as well. And there are numerous institutional trials ongoing with the combination of immunotherapy and SBRT as a synchronous combination of treatment modalities, but the data is evolving. So in conclusion, I think our highlights are that radiotherapy plays a niche role in the treatment of hepatocellular carcinoma, both in the bridge to transplant and definitive settings. It is a complementary therapy that works well with our multidisciplinary team-based approach, including our surgical oncology, medical oncology, and interventional radiology colleagues. And that, thanks for having me.
Thank you, Dr. Renz. That was a fantastic presentation. And as you can see, again, multidisciplinary approach is the key to treating all these patients. So I would encourage all physicians who have patients with HCC to make sure that they're presented at a multidisciplinary tumor board so you can come up with the best plan for the patient. And so we have one question for you from Dr. Klabuka. Does proton beam therapy play a role in the treatment of HCC compared to SBRT?
I would say it most certainly does. The issues with proton beam therapy are its limited availability. There's probably about 30 centers in the country at the current moment. And the benefit of proton therapy is not so much a targeting not so much a radiobiologic effect. It has the same effect as conventional photon radiation. What it really does, it has the ability to spare some normal tissues through the physics of a proton as opposed to a photon. And what that specifically means is there's no exit dose. I showed that one slide with the APPA beam arrangement, and that everything in between that got full dose of radiation. If that was a proton beam, you can put a single beam from an anterior or posterior arrangement, and it will stop exactly at the tumor location. So you'll still get entrance dose, but you won't get exit. And so that enables us to have some different physics to the radiation, which we can take advantage for normal tissue sparing. So in certain locations within the liver, proton beam radiotherapy enables a dosimetric advantage because it can spare some of the liver. They do the very similar dosing to SBRT and the same SBRT technique, but in peripheral lesions, it can be advantageous for sparing of normal liver. So same effect, but in select locations can be potentially less toxic. The downside being that it, at the moment, is a very technically challenging technology that is very cost prohibitive. A proton center costs anywhere between $50 and $200 million. So places like University of Pennsylvania have a $200 million proton center with 5 to 8 linear accelerators at any given time running. There are single gantry units like Case Western University has, which is a single gantry that's a $50 million unit. So as time progresses, I anticipate that those costs will be whittled down, just like all technology gets smaller, cheaper, and more pervasive in the community. And at some point in the next 5 to 10 years, our probably next progression is to have proton beam radiotherapy available across the nation more readily. So that's a loaded question. My short answer is yes, it does have a role, but at the same time, it's case by case and anatomy based.
Sounds good. Thank you very much for that.
All right, we are almost approaching lunchtime, but it's a pleasure to introduce our final speaker for today. And again, a reminder, we're going to break from maybe 5 to 7 past 12 until 1 o'clock, and then we have 3 case presentations. So please join in after the lunch break as well. So it's now my pleasure to introduce our next speaker, Dr. Mitesh Borad, who's going to talk to us about cholangiocarcinoma. So just briefly, Dr. Borad is a medical oncologist from Mayo Clinic, Scottsdale, Arizona. He currently directs the GI cancer gene therapy and oncolytic virus labs at Mayo Clinical Cancer Center, and is also the director of the Precision Cancer Therapeutics Program at the Mayo Clinic Center for Individualized Medicine. His research efforts are focused on development of novel therapeutics in liver, biliary, pancreatic cancers by really leveraging next-gen genome sequencing approaches, as well as applications of emerging areas such as the use of recombinant viruses with oncolytic and immunotherapeutic properties. His team was also the first one to demonstrate anti-tumor effects of FGFR2 fusion cholangiocarcinomas using small molecule FGFR2 inhibitors, which have now garnered FDA approval. So it's a real pleasure. This is, I think, Dr. Borad's second time to be here, and we hope to continue to engage him. Mitesh, welcome, and please take it away.
Thank you, Paul. Appreciate the opportunity to be with everyone here today. It's been virtual both times, so I hope to one day see everyone in person for this event as well. So the topic I was assigned was to review the current changes that have happened in the landscape for cholangiocarcinoma for diagnosis and treatment. So I will try to cover a lot of ground here in the next 30 minutes, but I wanted to just give everyone a flavor of how the field has changed very rapidly. So here are my conflicts related to research done with biopharma. So I will cover deeper insights into known targets with biliary tract cancers. As you'll see, next generation sequencing has become very much a standard activity now, even in clinical practice. I'll go over some examples where research and practice form an interface where we are continuing to simultaneously discover new approaches to treat these tumors, and we're able to apply them in real time. It may be valuable to understand the heterogeneity of response, even when things that have high response rates come across us. And then I'll go over some emerging tools such as liquid biopsy and ex vivo models. So biliary cancers are the second most primary cancer of the liver, typically adenocarcinomas, although they could have other histologies. Most are diagnosed at late stages, unfortunately. And for these patients, systemic therapies are the standard of care currently, which are mostly palliative in nature and extend life somewhat. So there's definitely a high unmet need. Shown on this slide are some of the etiologies such as liver flukes, metabolic syndrome, autoimmune conditions such as PSC as being the causative underpinnings of these malignancies. And while we have historically classified them by anatomical location, the new paradigm very much is a genomic molecular paradigm. And of course, it overlays on the anatomical locations to some degree as well. So when we look under our tried and trusted tools, such as the microscope, we can see that these tumors have a very complex microenvironment with tumor cells, supporting cells like stellate cells, acellular stroma, and the variability of immune cells, such as T cells or tumor-associated macrophages. However, the new tool in the current era even is what we would term the genomoscope. So shown here is what we use as a tool here at Mayo Clinic, which is called the genome plot, where we can map all chromosomes, including autosomes and sex chromosomes. And on the genome plot are shown rearrangements, copy number changes, and mutations, all on the same plot. And this gives a better perspective of the complexity of the genomic makeup of these tumors. So it looks similar in many instances under the microscope, but for each patient, you will see a very individual genomic profile. So a number of studies have leveraged next generation sequencing based advances to characterize these cancers. And you can see some of the initial reports here in liver fluke associated and non-liver fluke cholangiocarcinomas, and sort of different genetic patterns emerged even in these early efforts with genes such as BAP1, ARID1A, and PBRM1, which are all epigenetic regulators emerging in sort of that second report shown there. So I alluded to the discovery and treatment paradigm, and that arises from the ability to do bedside to bench research now. So typically, things would be taken from the laboratory through animal studies and then to patients. We flip this around a little bit because of the availability of sequencing technologies to start with the patient, see what may make sense, and then maybe treat the patient right there. And to better understand it, go back to the laboratory to hone the approach further. So sort of reverse engineering in a way. Shown there is Dr. Jeff Trent in the middle, who's the president and CEO of the Translational Genomics Research Institute, and he's holding a Circos plot. So this is only 11 years ago, as you can see, and now this is done very routinely. So that was one of the first solid tumor clinical genomes ever done, and 11 years later, literally hundreds of thousands to millions of these have been done and applied to patients. So when we think of genomic profiling, I like to use the elephant and blind men analogy, where everyone has a different idea of what genomic profiling is. But as you can see, the tumor's genome is much more complex than any one of these technologies will really capture, as I showed you in the earlier genome plot. And none of these are a wrong approach at the end of the day. All of them will provide some valuable information, as long as we understand it's not totally complete. We can keep advancing in the field. We can use these analyses for a variety of things. Germline analysis is critical. In fact, I would say cost aside, every patient with cancer should have a germline analysis done. You simply cannot tell by family history who will have a hereditary cause and who won't. Of course, we know that patients respond differently to different drugs, and from the same genetic profile, you could also assess pharmacogenomics. And then, of course, the things we usually use, these type of assays for selection of therapies, more and more response monitoring, prognosis, and clonal evolution. So when you have a very complex genome, it may be difficult to tell who is the driver. And when you can only give a single drug, sometimes you want to prioritize which sort of genetic alterations you go after. So a few sort of rules of thumb: if there's multi-platform concordance, you can rank events when there's copy number changes. If you have the same gene hit in two different ways, say a mutation and an amplification, that might give you some more confidence that that's a driver. And sometimes in RNA-seq data, you can have what we call mutant-specific transcript expression. So I'll start with concordance here. So you can see this is one of the early patients with FGFR2 fusions that was identified, and there was concordance between both exome data and RNA-seq data. So just from a research grade assay, we were quite confident that this might be a target already without having done any laboratory studies. So this patient was treated, and 6 weeks after treatment, some of the lesions disappeared and others became necrotic. And a few more patients had similar evidence of anti-tumor activity. So we took this to build upon the discoveries, and you can see now 7 to 8 years ago, these discoveries were made, and now there's already 2 FDA-approved drugs. So very rapid trajectory from discovery to clinical practice at some level. Okay, so once you have the target discovered, what types of things would one want to do? You'd want to develop a clinical diagnostic, maybe have some preclinical cell line and animal models to do further work. And of course, you want to take these things into clinical trials so you can establish what the value of perturbing these targets would be, and hopefully these things can make it to clinical practice. So here is the pathway, receptor tyrosine kinase pathway, where the ligand FGF binds to the receptor, causing dimerization, assembly of the scaffold, and downstream signaling that define the hallmarks of cancer. What is the prevalence of this event? It's about 10 to 15%, exclusively in intrahepatic cholangiocarcinoma. And of course, there can be geographic variations. Liver fluke associated cancers don't have much of these and tend to actually largely not be intrahepatic, but in the rest of the world, really, it'll be about 10%. An assay can be developed besides NGS assays. So shown here is a FISH assay. And when you have the fusion, you have this breaking apart of the green and red signals there on the FISH assay. And when it's intact, you have yellow normal signals. So just from discovery to assay launch in a CLIA setting took only a year. And my colleagues shown here are the ones who drove this endeavor forward. Animal models, there have been longstanding efforts at many institutions to assemble patient-derived xenograft libraries. In the past, these would be from various patients, but they would all be viewed similarly. Now with the understanding that the disease is very diverse and heterogeneous at a genetic level, characterization of these models has become very important. So in the early days when we had collected these, we collaborated with Dr. Roberts and Trudy shown here, and with RNA-seq and the FISH assay I showed you, one of the xenografts happened to be an FGFR2 fusion xenograft. So now we had a preclinical model system. Okay, and how can you use these? Well, here's a vehicle, so untreated model, and you can see that when you use an FGFR inhibitor, so the one we used at that time was ponatinib, you get anti-tumor efficacy, and this is exactly what was reflected in that patient that I showed. You can see it's not quite as good as standard treatments like gemcitabine and cisplatin, but would avoid many of the toxicities that you would get with chemotherapy. When you use more specific treatments like infigratinib shown here or davitinib shown here, they are more efficacious than ponatinib, and that has been borne out now with later studies. Infigratinib is an FDA-approved therapy as of this year. You could also maybe have modalities to rapidly identify these patients. So Dr. Al Silva and his team use machine learning methods to do a pilot study where they identified a different pattern with patients who have the fusion shown here. And more advanced techniques such as Fourier transform-based approaches allowed them to be even more confident in identifying patients just on imaging. Of course, this needs to be rolled out to larger groups of patients across multiple institutions, but might provide a much faster way to at least flag patients who might have these fusions. Currently, it takes 2 to 4 weeks to get sequencing data back clinically. Here are some of the drugs that were used in these clinical trials. So pemigatinib was the first one FDA approved last year. And you can see that in the waterfall plot, about 70 to 80% of patients have some tumor shrinkage, response rates in the 30% when you use the 30% cutoff line shown here. And these tend to last about 6 to 8 months on the average. And similarly with infigratinib, which got approved this year, you get a response rate in the 30% range. You can see 70 to 80% of patients have shrinkage, and they last about the same amount of time, 6 to 8 months. Some newer covalent inhibitors, such as futibatinib, have also been used and show, again, response rates in that 30 to 40% range. Importantly, these drugs may work in patients who have received prior first-generation FGFR inhibitors that I just showed you. And this is because of the binding site of this drug being different than the other ones, which is an escape mechanism. And that's shown here very peripherally. So with liquid biopsy assays, we could discern the mechanisms of resistance. And one of them is sort of polyclonal FGFR mutations. And you can see this patient has 4 of them here at a later time point. So some of these variants will not allow the drugs that were being used to bind, and this is an escape. This is a mechanism of escape. What about additional subsets for a validated target? So again, FGFR2, besides fusions, you can have mutations and amplification. So here's a patient who progressed on first-line therapy, had a mutation in F276C. Turns out that this location enhances dimerization. It's not in the kinase domains, it's in the extracellular domain. And this patient was treated with FGFR inhibitor, and you can see after a couple months, there is evident tumor shrinkage. It lasted almost 6 to 8 months. And then when we went back to the lab, we were able to show that these mutations indeed cause more pathway activation. So again, the bedside to bench paradigm. Why is this important? Well, 2 to 5% of patients have these mutations and not fusions. So if the fusion frequency is 10%, you could increase your pool by almost 50%, although this is a trick of numbers here, but you don't want to miss even a single patient to benefit with available drugs. Other targets, so there's also isocitrate dehydrogenase, which is a metabolic and epigenomic target. Its partner is IDH2. IDH1 is in the cytoplasm, IDH2 is in mitochondria. Normally, these are important in the Krebs cycle. When there are mutations, you get a neometabolite called 2-hydroxyglutarate, which has epigenetic effects ultimately and leads to oncogenesis. So these are found at about 15%, mostly again in intrahepatic cholangiocarcinoma. And a study was done called the Clarity study, which randomized patients to ivosidenib, which is an IDH1 mutation-specific inhibitor, versus placebo, with crossover allowed, of course. And patients had a much longer progression-free survival on ivosidenib compared to placebo. And there was a trend towards overall survival, but because crossover was allowed, this study was not able to demonstrate it with a technique called rank-preserving structured failure time, where you would kind of model what would have happened had you not done the crossover. It was significant, but on a pure basis, it trended but didn't meet OS metric. Either way, this was felt to be efficacious enough, and ivosidenib received FDA approval as well this year. So now there are 3 drugs in cholangiocarcinoma FDA approved when there were none specifically for the disease just a couple years ago. This is generally a very well tolerated drug with some gastrointestinal toxicities, which are typically grade 1 or 2, occasional QTc prolongation, and occasional neurological toxicity observed in other studies, not in the one we did. Mechanisms of resistance are still being elucidated, but As shown here, in this patient, at the time of progression, there was an IDH2 mutation noted. So genomic mechanisms of progression in these patients will be important to understand to make these responses more durable or develop newer approaches as we go along, just like we've done in lung cancer. Last target that I'll review here is BRAF. We know this very well in melanoma and colon cancer now. It is in the RAS-RAF-MEK-ERK pathway. And in a basket study shown here, where a lot of different tumor types with BRAF mutations were treated with the dabrafenib and trametinib combination, you can see 70 to 80% of patients in this waterfall plot having a benefit. Official RECIST response rate was almost 50%, and these lasted almost 9 months. So very, very effective therapy, I would say, in this group of patients. That alteration is at about a 5% prevalence, by the way. So shown here are some other alterations. You can see that biliary cancers are the most target-rich GI cancers. HER2, KRAS G12C, PIK3CA, other FGFR alterations, CDKN2A, MET amplifications. I would say 2/3 of patients ultimately will have a target as of today that could be intervened with. And studies will need to be done, of course, to develop the data that's robust enough for people to apply this in clinical practice. We know that patients who have microsatellite instability typically have very robust responses to therapy across most diseases. It's found at about 3 to 4% prevalence in biliary tract cancers. So if you find it, do you treat upfront or do you wait until they progress? We do see some differences in mutational patterns between various anatomical subtypes, with higher amounts noted in extrahepatic and gallbladder cancers. And we know that from a tumor agnostic perspective, we already have these antibodies available to us to apply, and that's based on the work that the Hopkins team and others had done with one of the seminal publications highlighted here. You can see that a lot of patients who had mismatch repair deficiency had deep and durable responses. You can see that the responses occur and then last a long time. This group also included some biliary tract cancer patients. So here's a patient who didn't get standard therapy because he refused it, and we gave him pembrolizumab, and you can see that this whole tumor burden is literally gone 7 months after treatment, and he remains this way 3 years later. Here's another young patient who had microsatellite instability, who had a large tumor here, was treated, but literally had no response and developed additional lesions. So we still have a way to go to understand who responds and who doesn't, even in these markers where we think we have things nailed. Immunotherapy is, of course, an emerging paradigm, and the investigators at the NCI have been doing studies where they make personalized T-cell therapies for patients. And here's, of course, the most famous example in the biliary tract cancer world, where a patient with an ERBB2 IP mutation received personalized cell therapy and had responses on 2 occasions. This patient, to this day, over a decade later, remains in remission. So clearly there's a very promising opportunity here if we can understand it well enough. Liquid biopsies currently do most of our sequencing on tissue. As we go further and further, I think we'll end up doing both, and we'll do liquid biopsy on repeated occasions. And we might be able to get the data sooner, of course, with liquid biopsy because it's just a blood sample. So it's fast, it's not as invasive, you can do it serially, and because it's a representation of the pool of mutations from various locations, it might be better representation of heterogeneity. You can use it beyond just target assessment. You might be able to use it also for defining response. I think RECIST will be a thing of the past in the coming years. So we had done some work in this realm, trying to define the landscape, and you can see can define usually the same alterations minus some of the fusions with this approach. And you can also get a sense when you do it serially as a patient who maybe has stable disease actually getting clinical benefit with these modalities. So here are all the uses that I listed. Of course, in addition to those, you also have minimal residual disease and early detection as things that will happen in this space. I'll close by going over preclinical predictive model systems. So there's organoids as shown here. And you can see that these are things you can grow in outside of the patient's body with the appropriate media. It may take months sometimes, so some systems may be more amenable to clinical application than others. And you can see that these preclinical studies at least provide some perspective, but 9 weeks may be perhaps too much for a patient. Here's an organoid that some of our collaborators generated, and we're using these to study new drugs that we should consider bringing into the clinic. And we are doing some work where there's a patient-friendlier approach called ex vivo, where we take the patient's tissue, sequence it, and in parallel also do real-time testing on what we call 3D microcancers, and then take that data back to the patient once we've figured out what drugs might be the best to use. Okay, so again, our just shown here is a schematic of that ex vivo model, and you can get these results in a month or less, and hopefully over time in 2 weeks or less. It does have very similar genetic features as the patient's original tumor, so it does recapitulate that. And here's an example, patient in his 60s who got first-line therapy. Here's what it looks like under the genomoscope. We saw a fair number of alterations. Tumor mutational burden was just below the cutoff where we could give immunotherapy. We did ex vivo testing, and immunotherapy was felt to be beneficial. So we took pembrolizumab and gave it to the patient off-label here in this case, and you can see that the patient had all their lesions disappear within a year. So just to close, genomic profiling is now the standard of care in patients with intrahepatic cholangiocarcinoma. We can use these bedside to bench approaches to do research, as I highlighted. We will need to get a deeper understanding of who responds and who doesn't. A target is not 100% predictive, and just keep the emerging modalities in mind, like liquid biopsy and organoids. I won't be the only one talking about it. Everyone will be using it anyway. So good to hear about it early and adapt it as things emerge. So I'll stop there. I want to thank patients and their families, all the funding agencies, and my many, many friends and collaborators whose work I showed here today. Thank you.
Thank you, Mitesh. That was fantastic as always. Really learned a lot. So again, we are waiting for questions on the chat. In the meantime, I just wanted to kind of pick your brain on the level of heterogeneity that is evident in cholangiomas, especially intrahepatic cholangiocarcinomas. And is there any concern that, and this may sound like a naive question, but we have some preclinical data to support that notion. So that's why I wanted to kind of ask, is there some sort of a competition that exists between clones that are being driven by different molecular machinery? In a sense that if you are able to kill specific clones based on molecular targeted therapy, could the other clones eventually become more proliferative and more expansive, and at the end you have a worse disease than not? Do you have any clinical evidence in that area based off the heterogeneity that is evident in cholangiomas?
Yeah, great question, Paul, as always. this is likely the case. You have the clones. We know patients with fusions have more indolent disease, for example.
Right.
And as you treat, you get a response, but then you're selecting for these very aggressive clones. And at some point, could you have backed off and kind of gone into a intermediate zone? I think that's what you're getting at. And I think yes, but no one knows how much you should push the pedal and where you need to stop, right? Like you probably don't want to eradicate the clone altogether, because then a more aggressive, even more dangerous clone is going to take over. And then you're going to have a rapid decline.
Gotcha.
So maybe with these liquid biopsy tools, you'll be able to measure where you're at, and you'll be able to sort of hit the accelerator and then hit the brake and kind of keep the car from, either stalling or going out of control, right? And I foresee that would happen, but that's going to be a paradigm that's never been explored in oncology in clinical practice. So to convince people of that is also going to be challenging. So I think people are going the other way there, where they say, well, let me just see what I can do to eradicate that more aggressive clone.
That's right.
And there has been some success there. Whether these are pre-existing or acquired is also a topic that comes up a lot. At least from what I've seen, it seems like they're always pre-existing, but just at very, very low levels that you just can't detect unless you go at 10,000x or 100,000x depth, where you might see one read out of 10,000. So you can see that you'll always miss it on a clinical assay.
That's right. Great. Thank you.
I had a quick question, Mitesh. Thank you for the great talk. So are you using ctDNA to monitor patients after they've just say had a resection of an intrahepatic cholangio, R0 resection, no high-risk features, you didn't give adjuvant therapy, but using ctDNA serially to detect recurrence sooner? And are there any clinical trials that are looking at that? In which space are we using ctDNA the most? Because there are these commercial vendors who can do this, like Signatera, Guardant. And so should we start utilizing this technology in that space?
Oh, absolutely. I mean, the challenge is that the data are largely in, say, colon cancer right now. But if one thinks about it, do you really need to do a study in every cancer? This is the folly of our ways in terms of evidence-based medicine. All the studies show immense hazard ratio differences, 10 to 50. I mean, you never see that with any therapies or any other approaches in the colon cancer world. So if anyone has minimal residual disease found on cell-free DNA, they are almost 100% going to recur. So does one really need to do studies in every cancer, knowing that this is a platform technology? I would say no. Mm-hmm. But given how things work, it's almost a given that these studies will be done and implementation will be delayed by 3 to 5 years, somewhere in that range. So unfortunate, yes. But that is clearly the way to go. There's no way to tell who's going to recur otherwise. Staging is probably useless as we speak. If you can measure something, there's nothing better than that.
Sounds good. Thank you.
That's great. Well, I think we have no additional questions from the audience, so we'll conclude the first part of our session. Thank you again, Mitesh, for this wonderful talk.
Yeah, thank you for having me.
Yeah, of course. Yeah. And then I think we're going to break for about 50 minutes or so now. And just a reminder, although the lunch break has been cut down by 10 minutes, if there's an opportunity for the audience to go into the booths to kind of, look at some of the products that our sponsors have to share, please do so. And then we will see you all at 1:00 with the 3 case presentations and then the conclusion of the program. Thank you very much. Bye.
Thank you. Welcome back, everyone. We are now moving on to our last presentation of the day. This is exciting because these are case presentations. And so our first speaker is Dr. Dheera Reddy. She's a second-year abdominal transplant fellow, and she's going to talk about resectable and transplantable HCC. Welcome, Dr. Reddy. You can go ahead.
Thank you so much for the introduction. So I'm Dheera. I'm one of the fellows at UPMC. I'm one of the transplant fellows, and I thought I would just present a couple of cases regarding advanced HCC and living donor liver transplant, as that is something that we do quite a bit of at the Starzl Institute. So I will, oops, sorry, that is not what I wanted to do. So what is the rationale for liver transplantation? So before I start, I wanted to thank everyone and all the presenters for all their extensive information and knowledge that we've had all day today on HCC. And one of the things that we discussed is that liver transplantation is an option for hepatocellular carcinoma, and it potentially for some could be curative and also prolong life expectancy. So like I said, treating the lesion, it allows, especially if HCC is multifocal, or it can provide oncologically superior margins. And it also treats the underlying disease, which is the cirrhosis, the portal pressure, and the hepatic function by giving a liver transplant. So there is a rationale for pursuing liver transplantation. Now, the purpose that I'm discussing living donor liver transplant is that it gives us a different way to address transplantation as opposed to not just deceased donor transplants, because as we discussed, there is a overall organ shortage, and to be able to provide organs to everybody that may need it. So living donor gives us a chance to maybe transplant people that fall outside of a category of being able to be transplanted, or gives us also a chance to plan and schedule at an optimum time for the patient, so that we're able to help more people. And as you can see, this graph is more of the representation of how UPMC has evolved in its living donor numbers. And as 2020, our projected was, we'd done about 100 living donor transplants. So that was, there is a growth in that. And also the fact that we've had good results. This is our SRTR data from 2021 of this year, with the observed and patient survival and graft survival being quite high. It does allow us to take higher risk cases, especially cases that may fall outside of Milan criteria when it comes to HCC. The next few slides are going to be about presentations. I will preface that with Dr. Christopher Hughes, who's our liver director. The next drawings that you will see are all him. He's an excellent surgeon as well as an artist, so the credit for the next few slides will be all him. So this is a patient. She's a 31-year-old female from Virginia. She developed abdominal pain back in August of 2014. It was biopsy confirmed hepatocellular carcinoma. She presented to us in November of 2014. At the time of her diagnosis, she'd lost about 20 pounds and also had undergone 2 TACE in October of 2014. So she presented to us and we worked her up because she had an extensive disease. As you can see, her entire liver was just fibrolamellar. HCC, this is clearly outside of any criteria for her to be able to be listed on a deceased donor transplant list, and also not really resectable at this point. So we had evaluated her for a living donor transplant to give her an option for being able to restore her liver function, also maybe give her disease-free survival. Our normal pre-op bone scan and chest CT didn't show any extra hepatic disease, and then so because of that, we were able to proceed. And she also had low fractional leaflet loss. So that also helped us say that we could maybe proceed with a living donor transplant from her molecular testing. So for her, she got a left lobe graft from her brother. So it was a living related. And this is pretty much what a left lobe graft will look like. So this is the blue on top are the hepatic veins. The red in the hilum down here are the artery. The other blue is the portal vein, and the 2 greens are the 2 bile ducts from this donor graft. So we attached the hepatic veins to the middle and left hepatic veins. They went to the left hepatic vein. Then we attached the artery let me see if I can get to the next picture. Okay. So the left hepatic artery was attached to the right hepatic artery from the recipient. The portal vein was attached to the main portal vein, and the two ducts were sewn as a single duct in a Roux Y to reconstruct the biliary enteric anastomosis. So this was her surgery that was performed. Her total operative time was about 12 hours. Her graft weighed 492 grams. She had good flows through her graft. The portal flow was about 1 liter a minute. And then so it was about 203 mLs per 100 grams of tissue, which is appropriate flow. She had good hepatic artery flow, and it was actually a low transfusion for a liver transplant. She only received 2 units PRBCs throughout the entire case for over 12 hours. This was her pathology, again, showing extensive tumor burden. Subsequently, she did well initially postoperatively, but at about a year post-op, she did develop pulmonary nodules. She was started on sorafenib and later added FOLFOX to her treatment. She also developed metastases to her cervical vertebrae, as well as L5, T7, and T8. She did die on January 21st, 2019, but her survival after transplant was 3 years, 11 months, and 2 days. So there was an extension to, being able to give her some more time with her extensive disease burden. So that's our first case. And I'm just going to quickly give another similar scenario. However, this one is a 47-year-old. She was diagnosed with fibrolamellar HCC back in California in 2001. The reason I listed this her entire course is that you can see that she was basically had several resections. She had initially even been accepted at UCLA for transplant because at that time she fit the criteria, but then she had lung mets and had to be removed from the transplant list. Subsequent to that, from 2010 to 2017, she had liver resections, lung ablations, had multiple rounds of chemotherapy, was even on phase 1 trials at UCLA, and subsequently had to be DC'd from that from elevated LFTs. So she presented to us early in 2018 with, again, with fibrolamellar HCC, and at this point also a increased ascites and a decreased functioning liver. She did not have any evidence of tumor anywhere outside the liver, and so we decided to accept her for a living donor liver transplant. With all of our cancer patients, we do begin all of our surgeries with a exploration, and she had a negative exploration. We did not appreciate anything extrahepatic on our initial exploratory laparotomy that would preclude us from proceeding with the living donor transplant. So on April 5th, 2018, she also got a left lobe in similar pictures as before. Here she had 2 arteries, and they were sewn to the right hepatic artery and the GDA. And then she had 2 ducts. Again, a Roux Y was performed. For her operative time was 15 hours. Cold ischemia was 164 minutes. Warm ischemia was 27 minutes. And she did receive about 6 units of PRBC and 1 FFP. Her pathology to reflect. Her postoperative course, she did have refractory ascites. There was concern that there was steel from the splenic artery, so she did go to IR post-op day 5 for a splenic artery embolization. And then currently for case, she has no evidence of intra-abdominal metastases, but she did develop pulmonary metastases on day 292 after her living donor transplant. But again, she does not have anything in her abdomen yet. She has had multiple ablations, and she's had removal of lung nodules. She also had a VATS for her lung lesions from 2018 to 2020. But she is currently still alive. She's 3 years, 6 months post living donor liver transplant. And currently, because of her lung metastases, she's on Lamantinib. So I think she's, still has gotten a chance progress for almost 4 years now, despite having a pretty aggressive cancer for 17 years. Thank you.
Great. That's those two cases are when you look at the first scan, you don't think that this patient's going to live that long, and looks like that she's the first patient had a pretty good outcome. So for us, we've never taken care of patients with these living donor transplants, and so post-op, how do these patients do? And is it this similar management like you take care of transplant patients? And the second question I have is, how does the donor do after having the liver resection?
So for the transplant, how we take care of them is very similar to somebody getting a full graft, because the idea is that they're getting the same amount of flows. I mean, we're not trying to change anything different in their size. They're still getting the same amount of flow that we're trying to give them with a whole liver. And the connections are all the same. So they do well post-operatively. Most of our living donors, straightforward ones without any complications, go home at the same amount of time that a deceased donor does too. So in about 7 to 10 days, we're able to discharge them from a hospital. There's no real aggressive changes in their management. In fact, I think sometimes some of our living donors, because again, like I said, we're able to get them at an optimum time. Their MELDs are on the lower end, or they are, cancer patients. So they're not as acutely sick as a very high MELD patient who may require an emergent liver transplant from a deceased donor liver transplant. So our patients do well. And for the donor, our donor post-operative stay is anywhere from, I would say, 5 days, 5 to 7 at max. And they're out of bed walking on day 1, and they're moving around and able to tolerate the surgery well and be home in 4 to 5 days.
Mm-hmm. Okay, very good. And I'd like to ask Dr. Barad that for these fibrolamellar patients, I don't know if we have any good data using atezolizumab and bevacizumab. Not sure what your thoughts are on that.
Yeah, I mean, these are the rare subset of HCCs. There have been reports of patients who got checkpoint inhibitors who had fibrolamellar who responded. So, in the transplant setting, it becomes a little challenging. You might not be able to use it later, but perhaps prior to the transplant, these things could be considered, because you saw both of the patients eventually recurred, and while the surgery helped, in these very young patients, we probably need to shoot for, even more than 3-4 years.
Yep.
I mean, the rationale of lenvatinib in fibrolamellar, I mean, are we treating fibrolamellar HCC as any other HCC? Because the molecular driver is very different. It's a fusion of this DNA JB1 PRKACA. I think it leads to protein kinase A activation. And so the point is, should these patients be at all treated with the same group of receptor tyrosine kinases, or we need to think about the biology of the drivers and then try to use something more specific rather than these just random RTKIs.
Yeah, I mean, it's the only tools we have at our disposal, so we don't want to feel like we're doing nothing. But as you said, the chance that it's going to do anything meaningful is already very, very low. The problem here is that the number of patients per year is so few that only academia is going to be able to solve this problem. Biopharma is not going to step in for such a rare cancer population, at least.
Mm-hmm.
Thanks, Mate.
Paul, Dave here. I have one comment for Dira. It was an excellent presentation, and I think it nicely illustrates both of these cases, that the first patient, while both patients were young, the first patient was an advanced stage 3 HCC, and the second patient was a widely metastatic lung met stage 4, and neither of these patients ever could get a standard cadaveric liver transplant. And so it shows you that in select settings, live donor, while they didn't cure either of these patients, if it can buy 3 or 4 years of life in a young donor, and you can do the donor operation with low morbidity, then it's an outstanding option.
Yeah, those are very relevant thoughts, Dave. I think it's a game changer from a perspective of if you bring, if you have a living related donor, especially in these types of cases, then the bar becomes low, and adding 3 years to someone's life when the disease was such advanced is really meaningful. So, that's definitely a great point.
Thank you, Dr. Reddy. That was yeah.
Thank you.
So the next speaker is Dr. Alexander Helfand. He's a PGY6 Hematology Oncology Fellow at AHN Cancer Institute, and he's going to talk about a patient with a non-resectable, non-transplantable HCC. And so Dr. Helfand, take it away.
Okay, thank you very much. So thank you for having me, and hope everybody is having a nice afternoon. All right, so this case is regarding a 70-year-old gentleman who came in complaining of some mild fatigue as well as some periodic right upper quadrant pain with radiation to the right shoulder. He has a known past medical history of cirrhosis secondary to chronic viral hepatitis, which I'll tell you more about in a minute, GERD, hypertension, and peripheral neuropathy. He is a former smoker, but quit about 25 years ago, has a distant history of alcohol usage, as well as IV drug usage, is retired from work as an engineer, lives alone, and of note, his longtime partner died of liver cancer about 1 year prior to his own diagnosis. So he had evidently had a liver biopsy in 1991, which had not shown any scarring or fibrosis. It's unclear exactly why he had this, but he says that he had had regular screening until 2019. He's diagnosed with hepatitis C in 2014, treated with Epclusa in 2017, since when there has been no HCV viral load found. Chronic inactive hepatitis B was diagnosed in 2017, but HBV DNA has consistently been below, it's detectable, but below the limit of detection. And he was noted to have F4 fibrosis in April of 2017 and given a diagnosis of cirrhosis with Child-Pugh class A, 5 points. CT abdomen of note was done in May 2019 as a result of an ultrasound for screening, and that showed an indeterminate 4.2 centimeter right-sided liver lesion. And then he had an MRI, which showed a 4.2 by 2.5 centimeter heterogeneous lesion, which was thought to be a hemangioma, as were several smaller lesions. He was advised to get a repeat MRI of the abdomen for surveillance in about 6 months, but he was unfortunately lost to follow-up. He reestablished care with GI in February of 2021, at which time the ultrasound of the liver showed enlargement of his mass to 9.3 centimeters, along with 3 other similar appearing hypoechoic lesions in the right lobe. I won't spend too much time on labs, but essentially some baseline thrombocytopenia, as well as moderately elevated transaminases and alkaline phosphatase. AFP was mildly elevated to 7.5, and synthetic function was preserved with normal INR and albumin, and hepatitis status was as discussed before. He had an EGD in April, which showed no gastric or esophageal varices, and did show some mild portal hypertensive gastropathy throughout the stomach. He had an MRI of the abdomen in March, and it demonstrated multiple left and right-sided lesions, the largest being 9.5 centimeters on the right, 1.9 centimeters on the left. And it was overall consistent with multifocal hepatocellular carcinoma with possible hemorrhagic component. Here I've placed the axial T2 sequences, just showing the evidence of arterial enhancement as well as peripheral enhancement at 20 seconds. And then after 5 minutes, you can see that there is washout of gadolinium contrast. CT was done to complete staging and demonstrated multifocal upper abdominal lymphadenopathy involving the paraesophageal, paragastric, and portahepatis nodes. So he was given a AJCC 8th edition clinical stage 4A with CT3N1 disease with regional lymph node involvement, and as such was deemed Barcelona stage C. So questions for the panel would be, what systemic therapy would you consider using for this patient? would you have considered TACE for this patient? And would you have been comfortable using Avastin, in theory, not in this patient, but in general, with a platelet count of less than 50,000? And that's something that's come up clinically.
So I think we can start with Dr. Barad. What are your thoughts on this patient?
Yeah, so I mean, now first-line therapies give you atezolizumab and bevacizumab as a level 1 evidence option. Obviously, applying it to patients in the clinic is a different story because the patients that were in the study were more robust, didn't have the kinds of concerns you would see in the clinic, like varices or low platelets. But you just always have to take the clinical context into account. So I would at least give it a try with the understanding that you could have a bleed. And if you do, maybe you don't want to re-challenge them, but the risk of dying from the disease is far higher than the risk of an adverse event. TACE, I guess when patients are this advanced, what would be the true benefit is going to be something of diminishing returns, a procedure you can do because you can technically do it. I hope, like other malignancies, that once patients are deemed to be quite advanced, that really the focus is on systemic therapy.
Dr. Klabuka, what are your thoughts on TACE? The patients who have systemic disease, there are ongoing studies looking at combination of systemic therapy with local regional therapies. If you had seen this patient in this situation, would you have considered TACE?
Yeah, it's an area, as discussed, that we don't have good data yet. We're looking at, combining with systemic therapies for those who are in stage C of the BCLC algorithm. But as far as meaningful impact on life expectancy, you're really looking at something limited. You can always, of course, consider local regional therapies in settings of palliation for pain or other symptoms. Pertinent to that, this patient does have a pretty preserved liver function as a child's A5 cirrhotic, so he would certainly tolerate a local regional therapy. But again, the bottom line is for somebody with multifocal disease, including extrahepatic disease, you're not going to derive much benefit outside of perhaps pain control in a palliative setting.
Thank you. And I see Dr. Renz is on. What are your thoughts? Would you offer some radiation SBRT to this patient, maybe in addition to the atezolizumab and bevacizumab, or would you want us to just proceed with systemic therapy?
Yeah, I think for this particular patient, the systemic therapy would be the most important. There's actually some toxicity data associated with the VEGF inhibitors and SBRT doses, so we would have to kind of hold that therapy to do any kind of sort of SBRT like radiation. So I would kind of defer more to the systemic therapy and reserve SBRT for more palliation if after progression.
Sounds good. Thank you. Okay, so Dr. Helfand, we can continue.
Okay, very good. Well, thank you, everyone. So for our patient, he was started on Viriad for prophylaxis of hepatitis B reactivation in anticipation of starting immunotherapy. He was started on methadone and oxycodone for pain control, and he started, as per IM Brave 150, he started cycle 1 of atezolizumab and bevacizumab in April of 2021. He has tolerated it very well in terms of toxicity. He has had some grade 1 thrombocytopenia, increased creatinine, nausea, and chills, as well as some grade 2 fatigue and peripheral edema, which resolved with diuresis. Restaging MRI in July showed grossly stable multifocal liver disease with increased central necrosis, suggestive of treatment response, as well as improvement in his abdominal lymphadenopathy. He's now completed 9 cycles of treatment and is doing quite well. So I'm just going to go over first-line systemic therapy for advanced HCC. This is a flow chart that one of the earlier presenters had shown, and our patient would have been placed in the BCLC stage C group, for which there are now a number of first-line options. And this graph, if anyone wants to look at the slides later, provides a nice view of some of the ongoing trials in each of these settings. These are the NCCN guidelines regarding therapy. And as you can see, we chose the atezolizumab and bevacizumab regimen, but other category 1 options certainly would have included sorafenib and lenvatinib. So in terms of systemic therapy, I Am Brave 150, as Dr. Manga discussed earlier, essentially was a trial of about 336 patients, which assigned patients to atezo-bev 2-to-1 versus sorafenib with a co-primary endpoint of overall survival and progression-free survival. It was a very high-risk population, 75% of whom had macrovascular invasion or extrahepatic disease, like our patient. These graphs demonstrate that there was a significant overall survival benefit, as well as a PFS benefit. And as of the updated results from last year, there was a finding of a median OS at this 20-month follow-up of 19.2 versus 13.4 months. This just shows the superior quality of life found with atezo-bev versus sorafenib. Objective response was impressive with roughly in the HCC specific RECIST criteria, 33% versus 13.3% objective response in the experimental arm. Adverse events were typical for these two drugs, focusing on immune-related toxicity with notable hypertension in both groups, increase in liver enzymes in both groups, diarrhea much more notable in the sorafenib arm, as well as hand-foot syndrome seen in the sorafenib arm, but not in the atezolizumab and bevacizumab arm. Similar rates of grade 3 and 4 events. There were I believe 4 significant bleeds in the atezolizumab bevacizumab group, 3 of which were GI bleeds. SHARP trial had been published in 2008 discussing sorafenib in advanced HCC, studying 602 patients, looking at similar co-primary endpoints of overall survival and time to symptomatic progression, also with a high-risk population that was fairly similar to that of I Am Brave 150, though with slightly fewer patients with extrahepatic disease. Like the I Am Brave 150 trial, only patients with child PUA were studied. And in this trial, there was a survival benefit found of 10.7 versus 7.9 months of median survival. Events as seen in all of these sorafenib trials showed notable hand-foot syndrome in the sorafenib arm, as well as diarrhea, and benefit with sorafenib was seen fairly consistently across the subgroups, as you can see on the left, perhaps with the exception of those with extrahepatic disease. The REFLECT trial was a non-inferiority trial of lenvatinib compared to sorafenib, and included 954 patients with fairly high-risk disease, and found non-significant differences in lenvatinib versus sorafenib, 13.6 months versus 12.3 months median overall survival, which was statistically non-inferior but not superior. And PFS was superior in the lenvatinib arm. The objective response notably was significantly higher in the lenvatinib arm at 24.1% versus 9.2%. This was statistically significant. In terms of toxicity, significant toxicity, as we often see with TKIs, was present in both groups, though the incidence of grade 3 hand-foot was much higher in the sorafenib group at 11% versus 3%. And in terms of hypertension, there was more hypertension of grade 3 or above in the lenvatinib group, of 23% in lenvatinib group versus 14% in the sorafenib group. The Checkmate 459 trial, which has not actually been formally published and peer-reviewed, but has been presented at ESMO, studied the use of nivolumab 1-to-1 versus sorafenib with a primary endpoint of overall survival. Inclusion criteria was ECOG 0-1 along with child PUA disease, so there were 5% of patients who did have child PUB disease. Median OS with a follow-up of 22.8 months was 16.4 months in the Nivo arm versus 14.7 months in the sorafenib arm, which did not meet the predefined threshold for significance. The results were very similar at 33.6 months follow-up, published last year. OS of about 60% versus 55%. And at 33 months now, almost 3 years out, 29% survival in the Nivo arm versus 21%. And while no significant difference in overall survival was reported, there was a fairly significant difference in grade 3 and 4 adverse events, with 22% reported in the Nivo arm versus 49% in the sorafenib arm, which is consistent with the use of sorafenib in the past and the known toxicity profile of nivolumab in many other malignancies. There was half the rate of discontinuation in the Nivo arm. So this is just a summary slide looking at the median overall survival across all of these trials. And essentially what we see is that across all of these trials for sorafenib in the first line leads to a median overall survival of approximately 10 to 14 months. And that the best data yet would be in the IM Brave 150 trial, which with an updated 15.6 median months of survival, median follow-up, has a median overall survival of 19.2 months. The data in the REFLECT trial confirms that lenvatinib is non-inferior to sorafenib with a more tolerable toxicity profile. So thank you very much, and I'll be happy to take any questions.
Thank you, Dr. Helfand. A question for you is, so the patient is doing quite well right now. What would you consider in the second line setting for this patient, whenever he progresses?
So there's very little evidence regarding what to do in the second line. Certainly if we look, I'll pull back to what our options are for second line therapy. My inclination would be to try a different TKI. I don't think that trying single agent immunotherapy would be a benefit in this patient who's gotten atezolizumab. Functional status remains quite good, so I would be inclined to try perhaps lenvatinib, but Ipi-Nivo would also be a promising option, perhaps.
Mm-hmm. Dr. Barad, what are your thoughts on reusing immunotherapy after immunotherapy?
It might work if you had an initial response. If you were an initial responder, I'm not sure you will have much of a salvage response with a doublet. I think it's still anecdotal, and we'd have to see even those patients who responded, did they truly progress? And in that setting, if you're using the doublet, are you recapturing any of those patients? I think, again, just because they're assigned to a line of therapy, people will try to use these options, but the rationale is not going to be that strong.
Yeah.
Another question I had was, sometimes when you start them on immunotherapy, you may see actually on the first restaging scan some progression, but the patient is doing well clinically, and just say there's no evidence of new disease. Would you consider continuing on the therapy if the patient is still maintaining performance status, there is maybe mild progression in the existing lesions, and no evidence of new disease, just because of that hyperprogression that sometimes patients can get?
Yeah, I mean, pseudo progression is quite rare, I would say. Of course, if there's any thought that the patient's benefiting, these will be the most effective therapies. So it would make sense to treat sort of through, as you're saying. I think just using scans alone is not the best way to assess response. In those patients who have tumor markers like alpha-fetoprotein, that can be helpful, and sometimes that may have improved a lot and give you a clue that this patient's responding. And I think newer techniques like liquid biopsy will further enhance our ability to, tell if someone is having a response or not in the coming years. I think this challenge of treating through will become a little less and less.
Great, thank you.
Thank you.
Okay, so we are now moving on to the third case. And Dr. Liu will be presenting a case on intrahepatic cholangiocarcinoma. Welcome, Dr. Liu. You can go ahead.
Thank you, Dr. Manga. It's wonderful lecture for the fellow today. I'm not sure whether to get a picture from the introduction there. It's a picture more than 10 years ago, so it's changed a lot. So anyhow, so we're gonna discuss the one case today, and then let me say, it's very straightforward. This patient is 74-year-old Caucasian gentleman with just hypertension, ECOG is 0. He's playing golf and some accident, the golf cart rolled over him. So part of the trauma protocol showed the liver mass below. The left side is CT scan, roughly 6 centimeters, and followed by the MRI. MRI actually shows that time is kind of this Alex the case. It's called the hemangioma. It's an atypical hemangioma, so we recommend follow-up. Fortunately, the patient did not lose follow-up, and then he passed medical history. It's good, just hypertension. There's no smoking, no cancer history from the family, and then follow the scan in 3 months. That's in November last year, and show the mass is getting worsening. And then it's from 6 centimeters to 8 centimeters. And we follow by the liver biopsy. That time it shows adenocarcinoma, positive CK7, CK19, negative CK20, TTF1, and CDX2. So they said it could be from biliary tract system, also upper GI or pancreas. So that time the patient got the colonoscopy, and then there's no any lesion in the large bowel, and also pancreas didn't find a lesion there. And then we got a staging scan to show there's a right rib, there's a lesion with circle around there. So given his presentation, he's diagnosed stage 4 with metastasis to the ribs and intrahepatic cholangiocarcinoma. That time is C99, it's normal, and CEA is normal. His performance status is pretty good. And then we go to, based on the ABC02 trial, we start gemcitabine cisplatin, and for somehow he got a cycle cisplatin, he did with the AKI, and then his kidney function never improved back to normal, so we replace cisplatin with oxaliplatin. So after 2 months, we do the scan, and we can from the left side, right side, the rib lesion still the same. Actually, it's mentioned about a little bit worsening. And also bizarre is he has no any long lesions, but in the medial sternum window, we can see there's some like a hilar lymph nodes, subcarinal lymph nodes. So we did the biopsy, and we want to know it's make sure that's not another secondary primary. So we get the 4 lymph nodes by the bronch, and they show still consistent metastatic, fully differentiated adenocarcinoma, and it's consistent metastatic cholangiocarcinoma. At that time we check an MSI, it's stable. And then he also did the EGD. We make sure there's no any upper GI tract, so their biopsy from the EGD also benign. So this is the patient followed with the cisplatin, a GemCist, and 2 months scan, it's progress. And then we wanted to next step. For the sake of time, I'm sure Dr. Mungo maybe we can ask our panel is any next step we want to do. Yeah. Oh, I can continue presenting the case afterwards. Yeah.
I think you can continue, Dr.
Sure.
Yeah.
Sounds great. Okay. So we do the next generation sequencing that Dr. Barrett mentioned about intrahepatic cholangiocarcinoma. They do have a lot of mutations. We say their tumor mutation burden is no 4, it's not high, MS stable, and he has FGFR2 with AHCYL1 fusion. So the FDA, they approved there's one called pemigatinib, which was approved last year, which this is the NCCN guidelines. So we did start the pemigatinib, and then it's 2 weeks on, 1 week out for 6 months. When we scan, we can see on the top, the top, there's a rib lesion still there. And then, but we see the primary lesion, mainly liver lesions, primarily just more necrosis. It's not getting bigger. And then bone scan on the left lower corner, it shows the patient had the hip lesions and some rib lesions, and then we got to radiate that part. So that's one so far, he's still ECOG is 0, 0 to 1, and then we just presented the case. Our understanding is patients still just bone lesion, we can radiate, and we will continue the pemigatinib. That's the case, Dr. Manga. Yeah. I have a few slides. Yeah.
I'll give Dr. Liu the benefit of doubt. He did not see this patient. This is a patient of mine in clinic. So some of the challenges we had with this patient is when his original biopsy was sent for next-gen sequencing, they sent it back saying QNS, which means quantity not sufficient. So that sort of delayed us finding the FGFR2. But, we put him on systemic chemotherapy in the meanwhile. The second thing that happened with this patient is that his liver lesion is responding quite well, but the rib lesion continues to grow. So we biopsied the rib lesion to see if he has some, resistance mutations, and the results came back exactly the same. He has the same fusion gene. And so I wanted to get Dr. Barad's thoughts on that. Is that, whenever patients progress, do you continue to biopsy them to see if they have resistance mutations? And then I'm sure there are clinical trials that are ongoing, testing these newer drugs that are targeting the resistance mutations.
Yeah, this case highlighted some of the challenges with identifying these patients. Which is why I mentioned there's other ways like FISH assays. When you have small amounts of sample, there's also liquid biopsy, although it doesn't capture all the fusions. That's another parallel way to find these, and you'll get the results back in 7 to 10 days. So potentially you could have had it sooner, but I think most patients get first-line therapy, and during that time they get some of these results back, which you guys did, right? So I don't think there was a downside. When patients have these bone mets, it might look like they're progressing sometimes, but with bone, we know that with the destruction of tumor, there could be bone remodeling phenomena that may make it look like it's progressing on imaging when actually you're even responding there. So typically when I see a response in the liver and changes in the bone that are sort of paradoxical, like just keep them going, or might just radiate the bone lesion and not stop, because maybe I'm not convinced that there's true resistance that's developed yet.
Yeah. So the challenges with pemigatinib were that with the starting dose, he did pretty well for a while, but then he developed significant mucositis and couldn't really eat and drink that well. He is obese to start out. He lost some weight. He was extremely happy that he lost the weight. And he said he wants to keep it at that, be at the same weight. So, but still that it came to a point where he said, Doc, I think we need to do something about this. So I tried a number of different things, and there's good literature published on how to manage mucositis in patients receiving these drugs. And so we dropped his dose 1 level, and he's doing fantastic now. Good quality of life. He continues to work full time. He's a businessman, runs his business. And so we'll continue on this pemigatinib therapy. The question will be is if he progresses on this therapy, what would be the next step? We have, FOLFOX. There's some data on second line. What about, okay, there you go. Dr. Liu has some slides up there.
Yeah. So this one, just quick overview for the stage 4, the intrahepatic cholangiocarcinoma. The category 1 is GEMCIS that Dr. Barad mentioned about. We're normally just waiting for the second line. Second line would be like a target therapy that actually FDA approved for the FGFR2. There's 2 medication, pemigatinib, infigratinib. There's 2. I know Dr. Manga, the patient actually very smart. He sent this medication. If the pemigatinib is not working, can we try infigratinib? So that's very interesting. The patient. Let me just quickly go over this. The ABC02 trial, that's published more than 10 years ago. That's gemcitabine versus gemcitabine with cisplatin. Actually show there's a survival benefit, like a 3 months PFS and 3 months over survival, and response rate 26% versus 15.5%. That's still considered the standalone treatment, first-line treatment, despite the patient had FGFR mutation, IDH1, or BRAF mutation, like Dr. Barrett mentioned about. So this is the incident what I mentioned about. Is I think Dr. Barrett also had the slide in the lecture, is that we're looking for the intrahepatic cholangiocarcinoma. We can see FGFR mutation actually 11%. That's literature show like around like 10 to 15%, but they also had the IDH2, also had the BRAF mutation. And then one of this slide showed FGFR signal is FGFR fibroblast growth factor combined with receptor, the downstream phosphorylation, and the transcription, and the survival proliferation. But then because we have a mutation that's just auto some phosphorylation without any, does not need the FGF to bind the receptors. So actually the pathway, they have a ROS pathway, ejectostat, and leading to transcription regulation not regulated, just keep growing, and then neogenesis, tumor invasion, and chemo resistance. Interesting, I find this article is FGFR2 mutation. They have AHCY01, that's our patient have, that's 10% we have this mutation, and FGFR actually have the BICC1, also have a PPH1LN. On the right side, I really see there is actually the 1, 2, 3, 4, 5 medications they here. Infigratinib, all the things is reversible binding to this mutation. But the futibatinib, that's irreversible. So I'm not sure that will be helping us in the future, because since maybe more potent, just the binding would be reversible. I think reversible would be more potent compared to reversible. And then this one slide put together, and then times limit there. This will show there's the 2 phase 2 study, which lead to FDA approval, infigratinib, pemigatinib. We see overall, there's a primary outcomes overall response rate 23%, pemigatinib is 35.5%. So actually I had the cohort A, that's the patient that only have FGFR2 mutation, they have cohort B and C. And then PFS is 7.3 months, infigratinib, and the pemigatinib 6.9 months, roughly only 7 months. For futibatinib has now reported, and then we know there's derazantinib, that's 5.7 months, and endartefinib, that's 5.6 months. But we know actually only 29 cases and 7 cases. And then next I want to mention about there's a toxicity unique for FGFR inhibitor that would be most common is 50 to 80%. We had elevated phosphate, and so we had to make sure that's patient on low phosphate diet. We have monitored this. Sometimes we have to hold the treatment, but our patient with Dr. Manga, we don't have to hold it because of the hyperphosphatemia. And then the unique toxicity that we have eye toxicity that has retina pigment epithelial detachment. So it's pretty rare, less than 5%, but we have to regularly have the eye exam from the ophthalmologist. And the nail toxicity, we can see the onycholysis. That's kind of the unique from the FGFR inhibitor. And this is the one I mentioned about this. They do have. I really like this. Pegozafermin is because you see the FIGHT 302 trial. That's a phase 3 trial. FIGHT 201. That's phase 2, and FIGHT 101. That's phase 1. And also the PROOF trial in infigratinib. They have ongoing to compare. Can we use a front compared to GemCis? And that's going on. And also, like Dr. Manga and Dr. Barrett mentioned about FGFR resistant mutation, about the primary or acquired. They do mention about the FGFR V565. There's could be mutation, could be resistant to FGFR alpha. And also, they want to mention about is possible combination with the other target agent. We know just not only FGFR, maybe mTOR. Also, there's a other pathway down the line from the FGFR mutation, and also is it possible combined with checkpoint inhibitor? So there's a lot of things to go. Yeah.
And thank you. Yeah, happy Halloween to everyone. So in this case, eventually he's going to progress. So what do you think, Dr. Liu? What would you give him as it would probably be a 3rd line therapy?
Yeah. So Dr. Maka, really, we wanted to know what is it? Because we have 5, but only have engraftib. I was just, is it possible to have cross, like sometimes resistance, maybe resistant to the pemigatinib, but maybe it would be okay to engraftib. But so far we don't have any data for those. The PFS is roughly 7 months. So if we cannot go that route, now we'd probably just the second line chemo would be based on the ABC. I think 006 trial that would be FOLFOX. We hope to have more data at that time from there's another TKI that's start with F. Yeah, that's a futibatinib, that's a reversible binding. I hope maybe have the data when he progress, we can maybe use that one.
Dr. Barad, what do you think?
Well, this field is evolving very rapidly. NCCN guidelines are like the Bible. NCCN Bible, I guess, is like the textbook that your uncle or aunt used to use when they went to medical school, right? Like, I don't think it's a good source to apply to your individual patients like this that have a specific genetic alteration. So we know that systemic therapies don't work that well in these patients. So giving a patient like this FOLFOX when you know the driver event is wasting a line of therapy in a way, right? Like they're going to get it for a few months, and if they don't respond, now you're 2 months, 3 months behind the 8 ball. It wouldn't make sense to give infigratinib because infigratinib doesn't have any more potency than pemigatinib in hitting any of the resistance mutations. So if they progress on pemigatinib, futibatinib could be an option because it hits many of the resistance mutations that might arise with pemigatinib. I'm hoping it'll be FDA approved this coming year, so the timing could work out. And then with clinical trials, there's a lot of next generation inhibitors in development. So there's allosteric inhibitors and inhibitors that can overcome the gatekeeper mutation you showed, V564 or V565F. That's the gatekeeper mutation right there. So there's already drugs in development to overcome that. So there's no need to really struggle too much. There's going to be a bunch of trials open that you can refer the patient to. And they're all oral drugs. So even if somebody lives locally, you might be able to achieve it.
Thank you.
Yeah. Thank you.
Dr. Klobuka, I mean, for patients with intrahepatic cholangiocarcinoma just limited to the liver, is there any role for palliative TACE, Y90, or any liver-directed therapy? And after you speak, Dr. Renz, if you could let us know what for just local therapy treatment options.
Yeah, thank you for the question. So there actually is a phase 2 clinical trial that was published in JAMA Oncology this past year, looking at combining radioembolization with GEM and CIS in the first-line setting for locally advanced or non-resectable disease, but without metastatic spread. And it did show an improved median overall survival of 22 months compared to the 11 months kind of standard for GEM and CIS. Now, again, phase 2 trial, limited number, phase 3 is ongoing and recruiting. So it's kind of exciting to see how that progresses. Now, one quick comment for your uncle's textbook, NCCN guidelines. While they certainly kind of progress rapidly and are updated, NCCN always states that the best place for care for a patient, if possible, is a clinical trial. And so for, encouraging, those who may be outside guidelines or outside the textbook to always look for those clinical trials as possible adjuvant therapies. And one quick comment on this case, when we talk about moving to successive lines of chemotherapy, this patient, per the imaging that you showed, seemed to have a mixed response, right? The primary lesion in the liver looked great, but you had that progression within the metastatic osseous lesions. And so this is where local regional therapy, whether that's with Dr. Renz and radiation therapy or even cryoablation of bony mets, if you can treat these so-called escape lesions, right, the ones or few oligometastatic lesions that are not responding, you can hopefully stave off the need to kind of progress to those second and third line chemotherapy options by treating the ones locally that are kind of escaping your current therapy modality. And so, again, multidisciplinary review is the bottom line. Your radiation oncologist, your interventional radiologist, all can help for these kind of solitary lesions that may not be responding and kind of prevent and delay the time until you kind of switch lines of chemo. So with that, I'll kick it over to Dr. Renz.
Yeah, I agree completely with Dr. Klobuka that, the oligometastatic states kind of are a hot topic in our field. And, we kind of define that as a, specific kind of poster child primaries like colorectal, renal cell, melanoma. And you wouldn't kind of necessarily throw cholangiocarcinoma into that mix, but when you have a specific subtype of cholangiocarcinoma with a driver mutation that has relatively controlled disease for a long period of time, going after those kind of oligomets to prevent kind of resistant mutations and resistant clonal expansion is kind of, in theory, beneficial. So I would kind of, go down the pathway that this patient may fit that kind of mold, even though it's a little bit outside the box. The exact number of oligomets is a floating number that is evolving classically, or I don't even want to say classically because it's so much new, but we kind of have a benchmark number of 4, less than 4. That's getting pushed to 6 or more. And this patient, correct me if I'm wrong, I think I kind of saw the 2 hilar nodes, which we would count as one site, a right iliac crest, and a rib lesion, as well as the primary. So this is a kind of perfect case for some sort of multidisciplinary management where, those osseous oligomets and the hilum could be easily taken care of with kind of hypofractionation and SBRT approaches. And then the liver could undergo a liver-directed therapy with something like Y90 and obtain kind of local control of all sites of disease and stay on a lower dose of the pemigatinib to suppress any kind of micrometastatic burden in the bloodstream and get kind of a stage 4 NED, maybe in another 6 months or whatnot. So you always kind of want to go down that approach with kind of a tempered, slow and methodic pace so that you don't overtreat them and they start to progress in the interim. So, I would kind of go down the kind of pathway of let's treat 1 or 2 mets, stay on the pemigatinib, then treat the primary, then take care of the other 2, and then you don't submit them to undue toxicity in that interim while you're kind of cherry picking these areas off. So it's an outside the box approach, but approach that is being kind of pioneered in a lot of cancer sites. And like I said, with a driver mutation based cancer like this particular patient, that would be an individualized approach. That's kind of what I would think.
Thank you, Dr. Klobuk and Dr. Renz. Any other comments from the presenters or from the discussants?
No, and thanks for a great conference.
Thank you, Dr. Geller. So I'd like to thank all the speakers for sacrificing their Saturday to be here and educate us and educate our audience. I'd like to thank the patients who attended today, and definitely want to thank the Community Liver Alliance, Susanna Masardis, Amy Logston, and the whole team, the whole Zoom team that kept us on time, on target, and everything went very smoothly. We're going to have this every year. We're spoiled now. So look forward to the next conference and invitations to speak again and give us an update on this very difficult cancer to treat. So thank you very much.
Yes, again, I just want to echo. Every talk was a wonderful talk. Everybody learned. This is one of those multidisciplinary conferences where we get an opportunity to hear from all the different areas that are involved in treatment of this complex pathology. So it was a true pleasure to have all the group talk from their perspective about the best way forward to treat these cases. Amy, are there any last minute thoughts or announcements from CLA?
Sure. We hope everyone found today's conference valuable. We want to thank our presenters for sharing their expertise and knowledge. And, of course, thank our sponsors and those in the exhibits, Allegheny Health Network, Pittsburgh Liver Research Center, AbbVie, who's our national sponsor of distinction, AstraZeneca, BMS, Eisai, Exelixis, Genentech, Highmark, Merck, Servier, and of course UPMC. And thank you to both of you, Dr. Dulab and Paul Monga, for your leadership as our course directors. And remember, take our online evaluation so that we can continue to learn and bring additional conferences to you in the future. We will be sending out the CME documents to you after the conference, and we hope everyone has a great rest of the day, and we look forward to seeing you as we provide more education to our providers. Have a great rest of your Saturday. Thank you.
Thank you. Thank you, Amy. Thank you, Melissa.